That's not a good option. Correct, correct, correct. So go to the source. Okay. Ask the educator to provide an in-service training about pain management. Is that pushing it off on somebody else? And you the supervisor, you gonna push it off on somebody else? Perform a complete pain assessment on the client and take a pain history. You got time to do that as the supervisor? Who should be doing that? Correct. So this question is all about making you understand, nice hair, that if you're the charge nurse, you ain't got the time to be fixing everybody's problems. Okay? So you got to go to the source of the possible problem and ask them about it. Right? Everybody got that? What do you pick that? What do you pick that choice? Huh? Raise your hand if you would have picked that choice. Oh my God. We failed NCLEX? You got to pick that choice. I'm talking about the right choice. The right choice, of course. What y'all talking about? Oh, you're talking about the last one that the option. Should be confusing you. You're supposed to be a registered nurse. Confuse yourself. Okay? Listen, I was kind of proud of y'all last night. Let me tell you what happened to me last night. Well, I thought of you. I thought of y'all. That's what I thought of. I thought of y'all. Yeah, because I work at 2 schools. So when you work at 2 schools, you have this thing where you go, when you're mad at one school, you go, well, my students in my other school wouldn't do that. So I was doing that last night because I got this new bunch. See, they make me teach PNs and RNs. And I forget sometimes the PNs are usually a little bit more what? Immature. Usually, yes. In the beginning, they're usually a little more immature. Okay, so, and they've got me teaching some basic subject because they have nobody else. They know how I feel about those subjects because they're too basic and I want to teach more and I can't because they can't even get the basic concept. So it's kind of like, all right. But anyway, so I'm going in there and I'm teaching them the respiratory system. Respiratory system's a piece of cake. Okay, ain't much to it. What are you doing? Exchanging gas, regulating pH, period. And then going through the ventilation, all the step by step, really breaking it down, really nice and slow. Really nice and slow. So then I get to the end. I think it's only like 20 slides they had to do. It was like 20 slides. Just 20 slides. We're talking PowerPoint slides. 20 slides. Just 20. Imagine, I got a 4-hour class, only 20 slides. You think that took a long time to teach? I had it taught in like 30 minutes. Not even fast. I know you're going too fast. No, it was slow. And I'd stop and I'd ask them a question. They couldn't answer it, of course. So then I'd give them the answer and re-ask the question like I do y'all all the time. And they're just staring at me. Not saying a word. And I said, come on, guys. I said, listen, it's hard to be a nurse. You got to understand nursing school is hard. You got to apply yourself. You got to try. I gave them the whole speech. And I had somebody raise their hand. So I was like, all right, here we go. Maybe I'll get somebody to say something positive and we can get this thing launched and they'll start interacting and everything will be great. This person says, I don't know about everybody else, but when it comes to me, you can't tell me what hard work is. I'm only going off of what you're displaying, first of all. I didn't say nothing. I wanted to hear this. But I'm only going off of what you're currently displaying. You are not currently displaying hard work. You're currently displaying the lights on, but nobody's home. And then she throws this at me because I'm a veteran. You can't tell a veteran what hard work is. First of all, I'm also a veteran. But I ain't say that. All I said to her was, listen, if we were talking about the military, then yeah, you may be right, but we talking about nursing school. It doesn't matter what you did before you got here. It matters what you're doing right now. Do you guys understand? It don't matter what you did. It don't matter what I did yesterday. It only matters what I do today. Do you understand that? As a nurse, that's the way you got to look at it every time. It don't matter where you came from, what you got, what you learned, what degree you got. It don't matter how good you are. That's how you were. It's about how you are. Do you understand that? Every single day. You can't sit on your medals. You can't sit on your medals. Do you guys understand that? Every day, in a blink of an eye, the circumstances could change. And you're still going to have to execute just like you bragged about you did in the past. Right now, you got to keep it going. Do we understand that? That's the message for today. It ain't about what you did yesterday. It's about what? That's what it's about. And that's what it's always going to be about. The number one saying, in order to be great, you got to be great. In order to be great, you got to be what? That's continuous. Okay? All right, so we did good on that one. Let's do one more, and then we'll get into some of this farm. Let's do one more. This is a good one. This is a really good one. You're liable to encounter this. So the family members are encouraging your client to tough out the pain. Tough it out. Rather than risk drug addiction to the narcotics. The client is stoically abiding to this. And you recognize that the sociocultural dimension of pain is the current priority for the client. Who should you talk to and what should you say? No. Ask the patient what they feel about their pain and addiction and the possibility for addiction. Do you feel that taking this pain medicine, you may become addicted to it? Do you understand that? Educate your patient. Let your patient make a fair choice. Do you understand that? Because you're the best one with the education for that choice, not the family. Do you understand that? So the answer was, what do you believe about pain medication and drug addiction? And who are you asking? Because that's your patient. Do you understand that? And you may have to do that sometimes. You may have to step in. Because the family does put pressure on the patient. And you need to strengthen your patient with education when that happens. Are you listening to me? When the family's dominating your patient, what do? Educate your patient. Are you listening to me? Okay? Very good. That's 2 for 2. We're going to call that for 2 for 2. All right, let's get into this pharmacology. So, in my book, my outline book, it starts with the skin. Okay? Starts with the skin. So, do we understand the functions of the skin? Let's start there. Functions of the skin. Protection from what, though?
Bacteria.
Microorganism invasion, but protection from what else?
Temperature.
Well, that doesn't fall. That's thermoregulation, but very good.
Viruses.
Water gain, water loss.
Yes.
Why, when it rains, we don't blow up like a sponge? Because this repels that fluid, right? So it controls water gain, water loss, microorganism entrance. And then you said thermoregulation. We talked about that yesterday, core and surface temperature, right? All right, what else does the skin do?
Isn't it like the largest organ?
It is the largest external organ of the body. But what does it do? Come on, we're almost there. Ouch. Sensation. Not just pain, sensation. Touch, pressure, pain, all that, right? Sensation. You call that sensation, right? Sensation. You got these dermatomes that are connected to the spine, and they relay these sensations, these sensory neurons. Sensory neurons. What else does it do? What else does it do?
Excrete. Like sweat.
Yeah. Well, that's thermoregulation, but what you're trying to say is it helps get rid of things like medication. Medication comes out in your sweat. Did you know that? So it can help get rid of toxins. But there's another thing, very important thing. Look at my Look right here. What do you notice about this area of skin compared to probably this area of skin? What is the tone? Darker. Why? Melanin. It produces melanin, doesn't it? And protects us from the what? And then what does it get from the sun that's beneficial? Say it loud and proud. So vitamin D synthesis. Do you understand that? Let's talk about the skin again. Let's talk about the skin again, but quicker. What does the skin do? Protect. Sensation. Thermoregulation. Vitamin D synthesis. And helps with excretion. And produces melanin. Do we got that? Do you have a good understanding of the skin? What are the three layers? Quickly. All right, pay attention. Epidermis all day. What do you need to know? One thing, avascular. Epidermis all day. What do you need to know? No blood supply. It's a hard protein. Keratin, hard protein. Okay? The dermis, what do you need to know? That's the true skin. That's where all the blood vessels and nerves are. And the hair follicles. Where are they? In the dermis. And then you can call it the subcutaneous, but it's also called the hypodermis. Don't get it twisted. What is the subcutaneous or the hypodermis layer? That's the fat layer, the adipose layer. Insulates and protects the organs, right? That's just the basics on your skin. We got to know about the skin. Do we know about the skin? Now, let's talk about skin disorders. Let's talk about the skin disorders. Look, break out a piece of paper. I want you to do this. Get this. Keep this separate. Keep the med surg stuff separate from the pharmacology stuff. We're going to be doing a lot today. And you got to keep it organized. Somebody said, you like to jump around. Jump around with me. Jump around. Jump around with me. These are the things you want to make sure you know before you go into NCLEX. Contact dermatitis. You want to know that. Contact dermatitis. That's when you get exposed to some type of irritating chemical. Do you understand that? That starts a hypersensitivity reaction. You want to know what contact dermatitis is. Going into the NCLEX. Do we understand that? Okay? You want to know what pediculosis is in tinea. You want to know what pediculosis is. What is pediculosis? Lice. Say it twice. Lice. You want to look into the treatment for lice. You want to know about the Quell shampoo. You want to know about not only putting the shampoo, but you got to comb it out to get the nits. Do we understand that? You want to know about permethrin cream. Write these things down. These are the things you want to be studying. Do you understand that? You want to understand the application of permethrin cream. You're going to put that on twice. Do you understand that? You're going to put it on twice, leave it on for several hours, shower, wait a week, and do it again. Are you listening to me? For permethrin cream. They can use permethrin cream to treat lice. They use the Quell shampoo mostly. But you can... They can use it for scabies as well. But usually with the scabies, you want a scabicide, something that's specific to the scabie. They do use permethrin cream though. Are you listening to me? You got to know that. The chemical don't kill the nits. How do you get the nits out? Comb it out. Do we understand that? What is that called? Lice? Pediculosis. And depending on where it is comes the other term. If it's on the head, pediculosis capitis. If it's the body, pediculosis corpus. Do we understand that? And you want to know what tinea is. What is tinea? Ringworm. What is tinea? But it's not actually a worm. You understand that? Okay? You want to know that. Going into NCLEX, I got to know the difference. Impetigo, write it down. That's a bacterial infection, right? Most prevalent in children with the honey-colored crust around the mouth, right? And the intervention, don't pick the scabs, right? Because it'll bleed, right? Hello? Come on, let's get this. Okay? Contact dermatitis, pediculosis, tinea. Go ahead and write psoriasis down there. You got to know what psoriasis is. That's highly tested. What's highly tested? And you learned that in med-surg, didn't you? Silvery white scaly plaques. Huh? What do you say? Creatinine? What is creatinine? You talking about keratin? What do you mean? All right, very good. Listen, what psoriasis is, pay attention. It's an autoimmune disorder. Do you understand that? Psoriasis is a what? It causes hyperproliferation of skin cells. So instead of just producing the normal skin cells, they'll just stack and stack and stack and stack and stack and turn into a plaque, a plaque, a plaque, a plaque. Do you understand that? And the body will attack, 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 attack. You like that? Sound like a track, a track, a track, a track? Come on, it's Thursday. Y'all should be happy. Y'all sitting up in here Monday with the long face. And now we at Thursday in the driver's seat. 1 day to go. 1 day to go. Hold on a minute. I want to get to the med surge here and get the skin things in here as well. Hold on. I wonder if I can use this. Hold on. Let me see if I can do it like this.
Did you send us this?
No, I mean, yes, I did. But I'll send it again. It was a while ago. But I will send it again. If you're asking me if I sent it, that means you didn't read it. Hold up. No, I guess I can't click on it, huh? There ain't no easier way to move that. Let me see. Oh, okay, the page numbers are on there though, right? What number is that? Oh, I need 74. That's what it said, allergies. Aha. Here we go. We got some skin stuff. Let's talk about this skin stuff. Okay? Ain't got much. We know what mites are? Do we know what mites are? We got to know what mites are too, right? Mites and how to treat them. Look what it says. Where's it usually found? What are the interventions? With what kind of water? Know what? What else can you do? And then do what to the things you can't wash? And put them in plastic bags and suffocate them, right? Let's look up impetigo, though. Let's look up impetigo. Look up impetigo. Come on, let's get some work. Impetigo. Let's look that up. There's got to be, see, they just be chilling on some things. Oh, I can? What I'm looking for? Where? Right here? Guys, I sent you this probably a long while ago, but I will send it again. Okay? You want it now? Is that what you're hinting around to? All right, hold on. Oh, I hope we don't have to play this game. Come on. Every semester does this. What is this? Better work. All right, very good. All right, what am I doing? What cohort are you? And then there's some scragglers in here too, right? 41, 42, 44. See, I can't do it like that on here though, can I? Yeah, there's my capstone day. Just gonna take a minute. Hold on a minute. No. Hold on. Is that yeah? Where does it say? No, that's wrong. Where's students at? It's supposed to say students. What is going on? Let's start this over. All right, hold on. This you pick capstone. This where is students at? Man, where are the students at? I ain't got time for this, man. All right, listen, I'm gonna have to send it through the email. I hope everybody can get it through the email because they're not letting me they probably switched all things around because it's semester, so I can't send it to you through Canvas. What did we say? What card?
41,
42 and 44. Oh man, are you kidding me? I just did that. Come on, man. Tell me that ain't stupid. To get in the email. Come on, man. Am I that high tech? Got some FBI stuff going on over here. Authenticate. 209. Okay. They're making sure nobody don't get in that email, but oh, thank you. Appreciate that. Let me use my email. Okay, we said student 41, 42, and 44. Right? Anybody else and not in those three cards? That's it? Last call for all right. Yeah, you like that, right? Yeah, you waiting on the rest of that, weren't you? I had to cut that. All right, hold on. I'm gonna send you something else because I know you're gonna ask for it as soon as I start using it. Where's there it is. The pharmacology study guide is also what I'm using. Now you gotta be about that life to want to use that. Yeah, you gotta be about that life to want to use that Word document. But it would help you greatly if you would do that. Okay. Look at all these emails that just popped up. I'm just now getting these. Look at this. That's crazy. No, when were these sent? Y'all sent this morning? All right. Well, anyway. All right. So see, because this is the Word document that I'm talking about. I did a full outline on the entire pharmacology. Okay. No, it wasn't originally for you. Originally, I did this. I did this for my other school, but I'm gonna give it to you too. And listen, this thing is solid, man. Listen, this thing is solid. It gets to the point. It breaks it all down. If you take your time and do a little by little, you will learn a lot about pharmacology. Are you listening to me? Instead of just trying to learn the most popular meds. You learn all the classes, all the things that you need to learn. Okay? All right, where would I want to start? See, it even goes into how to put eye drops and ear drops and all that. Nose drops and rectal suppositories and vaginal and dry meter dose inhaler, dry powder inhaler. You know you don't shake a dry powdered inhaler. Do you know that? Did you know that the inhalers are always supposed to be sitting upright? Did you guys know that? We have a bad habit of what? After we do them, we just do what? Throw it back. They're supposed to be sitting upright at all times. That's why you're supposed to keep it in the box. The box keeps it upright. Did you know that? Okay, I didn't know that for a long while. Okay, and then we get into the tubes. Let's get into the tubes here. I know we kind of went over that, but these are important. Could be very highly tested. You know you got to flush that tube, right? Hello? Completely dissolve crushed tablets and capsule contents into 15 to 30 mLs. And you're really supposed to crush the meds individually. Did you know that? If you ever get followed by pharmacy or state, you better not crush all those meds at one time. It changes the molecular structure of the medication. And not only that, how you going to tell the patient which is which if you got them all crushed up together? Because you're supposed to be letting the patient know what med they're receiving. Do you understand that? Because what if they want to take one but refuse another, but you got them all crushed together? So you're supposed to do it individually. If you ever get followed, make sure you do that. Okay, you got a verified tube placement. Okay, flush before and after, right? All right, then we got what's the best site for infants 1 year and younger if you've got to give them injection? Vastus lateralis. Then it says the ventral gluteal site is preferable for IM injections and for injecting volumes that exceed 2 mLs. What is the maximum amount that you should be putting in that deltoid? 1 ml. Everybody got that? And you're going to run into old school nurses. They're going to tell you, oh, you can put 2, 3. No, you can't. 1. Don't blow the muscle. Okay, intradermal, we understand that. We do the PPDs, and that's usually the dose, right? Okay. Do not massage the site. Okay. If I pass something on here and you want me to go into it, let me know. But some of this stuff is common sense, right? Right? Or no? We need to baby it all? If we do, we do. Okay. These are the gauges. Look, it goes through the gauges. When should I use the 16? Basically for what? Trauma. 18 to 20 for what? Okay, 22 to 24 for who? Children, older adults, and those that have medical issues or are stable postoperatively. Okay. In newborns, what do we use? Veins in the head, the legs, or the feet. Okay. Do we know what the Z-track is? That's important. Whenever you're giving a med that's considered a what? A vesicant. Whenever you're giving a med that's considered a what? We use what method? It doesn't just apply to iron. Anytime you're injecting a med that could be caustic to the tissue, you use what method? Everybody understand what the Z-track is? You're pulling the skin taut, which is displacing the layers. You inject the med, pull the needle out, let the skin go, and the layers will start stacking on top of each other, and it prevents the med from leaking out of the tissue. We got that? Okay. Yeah, we know that we ain't got time for all these learning that drug. You know them pregnancy categories, right? Listen, let me teach you a quick little tip on these. A is okay. B is be careful. C is use caution. D is only if they're going to die. And X is never. Do it again. A is what? Okay. B, you better be. C. And what we mean by that is you got to weigh the benefits against the risk at C. If the benefits outweigh the risk, then you're going to give the class C. If the benefits don't outweigh the risk, you're not giving class C's. Are you listening to me? The only way you're giving class D is if what? To save their life, to prevent them from dying. No other option. And under no circumstance do you give class what? Okay? We understand the difference in prescriptions between routine, single, one-time, stat, and PRN. We understand the difference between all those. Okay? We know our rights. We know our 3 checks and our rights. The 3 checks. Do you know the 3 checks? When's the last check done and where? At the bedside in front of the patient. We got that? You're supposed to check that med 3 times, right? 3 times. And you better do that if pharmacy or state watches you. You better do that at the cart when you pull that med out the drawer. Compare the card to the MAR. You better do it again before you before you pop it in the cup. And I'm not talking about popping it in the cup. I'm talking about popping it in the cup. And then you got to open it in front of the patient in the room. Are you listening to me? You better do all that stuff. They're going to be watching you. And you go get a ding. And then you go get a write-up. Then you're going to have to do an in-service if you don't be doing these things. Okay? All right, where are we at now? Okay, now it goes into our sedative, hypnotic, anxiolytic. Look what it says. It's a sedative, so we can use it for what? Sleep. Okay? It's a hypnotic, so we can use it for what? Distraction. Okay? So it's an adjunct to pain or anesthesia. And we can also use it for what? Anxiety. And we're talking about the benzodiazepines. Do you understand that? The benzodiazepines can be used for what? They should put seizures on there too. Okay? What can the benzodiazepines be used for? Sedative, so it can help you what? Hypnotic, so it can do what? Distract, so we can use it in combination for anesthesia, right? You ever heard of midazolam? Okay? And we can also use it for what? And we can also use it for what? That's not up here. Everybody got that? Okay? And then the majority of them have PAM. Not all of them, but the majority of them have PAM in it to try to remember. Diazepam, lorazepam, chlordioxyperoxide, clorazepate, oxazepam, and clonazepam. We got that? You got to get familiar with those names. Get familiar with those names. When you're talking about benzodiazepines, you got to be able to identify one. Can you identify one? Benzodiazepine. Cold. C-O-L-D. Triple C, cold. Not only am I cold, but I'm cold to the third. Do you understand that? C-C-C-O-L-D. Now we're talking about the benzos for you and me. C-C-C-O-L-D. Are you listening to me? Make your work short. C-C-C-O-L-D. What does the first C stand for? Come on, don't play this morning. Come on, don't play around. Come on, we got to finish strong. We're almost at the finish line. Look, are you going to be that one? I'm celebrating. What just happened? The guy ran right past him. Did you see that? Yeah. The Olympic athlete thought they was going to go ahead and win the Olympics and started pulling up and celebrating. And the person came right by him and went and beat him. Yeah, because they was being stupid. Okay? The first C stands for what? Chlordioxyperoxide. What about clorazepate? What about clonazepam? Chlordioxyperoxide, clonazepate. What else? Clonazepam. Guys, you got to be able to know how to identify these. They're going to insert these in questions and ask you to determine what med it is. That's a what? That's a benzo. How you know it's a benzo? Because it's C-C-C-O-L-D. C-C-C-O-L-D. Okay, benzos are straight up cold, ain't they? Are benzos cold? Them benzos, those Mercedes benzos, they cold. The BMWs are hot. The Mercedes is cold. The benzo is cold. How do you know they're cold? Because the antidote deals with the flu. The antidote deals with the what? Do you hear me? What's the antidote for benzodiazepine? Flumazenil. So we know the benzos can cause a what? A cold. Are you listening to me? What's even worse than a cold? A flu. So that's how you counteract the cold, get them with the flu. Add the benzos to your crew. C-C-C-O-L-D. Okay, and we know what they're used for. They got a multitude of uses, don't they? Okay, let's look at some of the stuff that they can cause, though. Okay, let's look at some of the stuff they can cause. They're also used for alcohol withdrawal. We didn't say that either, did we? Well, it's to prevent the seizures, okay? Now, of course it causes CNS depression. It's a CNS depressant. Okay? But look at this one. You might not have thought about this. Look at this here. Anti-retrograde amnesia. Anti-retrograde amnesia. They'll have difficulty recalling events that occur after dosing. Especially that midazolam, right? Retrograde amnesia. Nothing else stands out. You know it's a CNS depressant, so you know it can cause what? And you know it's a CNS depressant, so you know it can cause what? Are you listening to me? You associate CNS depression with what two major organs? Heart and the lungs. You associate CNS depression with what two major organs? And there's another one, ain't going to kill him, but it's going to be a problem. It's the kidneys. Are you listening to me? You suppress the CNS, they ain't going to be doing what? Peeing. Okay? It says this med, well, all meds can have a paradoxical. Do we know what paradoxical means? No, the opposite. The opposite of what was intended. So instead of relieving the anxiety, this could cause what? Instead of allowing them to sleep, this could cause what? That's what paradoxical means. The opposite of the intended effect. We got that? Okay? And then look at the withdrawal effects. All the withdrawal effects are going to be the opposite of what the medication is intended to do because you no longer have the medication to do it. But look what it says. It's a pregnancy risk category what? D. So that means the only way you would give this med is to prevent them from what? Okay? But it says, look, it's contraindicated. Contraindicated. You don't give a benzo to someone with sleep apnea because of the respiratory depression, and you can't give it to somebody with glaucoma. You can't give a benzo to who?
Sleep apnea or respiratory issues.
You don't want to give it to them with glaucoma. It's going to affect that intraocular pressure. Are you listening to me? Benzos can affect what?
Intraocular pressure.
And then here's a good one. Here's a good patient teaching about it. What should they avoid while they're taking the benzo? Why? It can reduce the metabolism and cause it to be toxic. Are you listening to me? And also, what else could reduce the absorption? We're talking about the benzos. What are we talking about? Okay? We're talking about the benzos. And then I want to paint a picture while we're on this subject. I want to paint a picture. When I teach the anti-seizure meds, I break them down to three classes. The mild, the moderate, the severe. The mild, the moderate, the severe. The benzos are the mild. Even though they're used for acute situations, the level of respiratory and blood pressure fluctuations is mild in comparison to the other two. The moderate is the hydantoins, the phenytoin. Listen, put this together. Put this together. Put these benzos together. Put them somewhere. Put the benzo right above the what? Put the benzos right above the what? The hydantoins. The phenytoin, the hydantoin, the phosphophenytoin, the hydantoins. That's the moderate. What's the mild? What's the moderate? Hydantoins. You can call it phenytoin. Just call it phenytoin. But the class is called hydantoins. The class that phenytoin comes from is what? Hydantoin. Okay? And that's phenytoin or phosphophenytoin. That's the moderate, right? Is that the moderate, the mid-grade? And the most severe is your barbiturates, guys. The most severe is your what? And we're talking when it comes to respiratory depression and blood pressure fluctuations. Are you listening to me? What do we have for our anti-epileptic drugs? What is the lineup?
Benzos, barbiturates.
And for the phenytoin, you remember that gingival hyperplasia. That's overgrowth, excessive growth of them gums. You also remember phenytoin can interact with so many other meds, including your anticoagulants. And you need a second form of birth control with the phenytoins. Are you listening to me? The barbiturates, you really want to be careful with them. Phenobarbital, secobarbital. You want to be careful with them because there is no antidote. They're very powerful and you could kill somebody. Are you listening to me? Usually the benzos by themselves will not cause respiratory depression. What you got to worry about with them is when you give it in combination with another CNS depressant. Are you listening to me? Do you have the 3 level? We're going to be doing a lot of leveling today with drugs. You got to put these drugs in categories. You got to have something in your mind. When I think of seizure drugs, the first one I think of is what? Then I think of my what? Then I think of my what? Do you understand that? Even though I know they got multiple uses, especially the benzos, they're anti-anxiety agents as well. But guess what? They're anti-anxiety agents. And when we're talking about anxiety as far as psych, I know we can't take these that long. Do you understand that? How long? What's the longest you should be taking that? 3 months. 3 months. What's the longest you should be taking a benzo? Okay? They're acute meds. You remember, they're acute meds. Benzos are a little cute, ain't they? Huh? Especially the emblem. That's about it. The emblem's nice. Okay? So we got our benzos down pat. We talked about this one yesterday with the psych meds. What is the med here? Buspirone. Buspirone. Okay? We ain't gonna do the psych meds again. We did them yesterday, right? Right? Are we pretty confident with the psych meds? What's the number one side effect of SSRIs? No, that is not a side effect. Listen, pay attention. Pay attention. A side effect is something that is expected to happen. Dry mouth. A side effect is something that is supposed to and expected to what? An adverse effect is something that we don't want to happen. If this happens, we got to stop the med or change the dose. Are you listening to me? Now, this is where it gets creepy. A side effect for some people can be an adverse effect for other people. Are you listening to me? Prime example, ACE inhibitor. In some people, that ACE inhibitor will cause a dry hacking cough that will go away. And other people, that dry hacking cough will not go away and it'll be severe and prevent them from sleeping and cause soreness from the constant coughing. And in that case, it becomes an adverse effect and you got to switch them to the ARB. Are you listening to me? So for some people, a side effect could be a what? But a side effect is something that is what? Expected. And it shouldn't be anything that makes you want to stop the med or change the dose. What is the thing about trazodone? We didn't talk about trazodone yesterday. The atypical. Look at this. Look at this. Look at this. You need to know about old trazodone, trazobone. Trazodone can cause that condition called a priapism, where the erection that won't go away. Do you understand that? That's serious business. So you remember that saying, trazodone, trazobone. Okay, that's serious. You got to know that. Okay? Oh, we didn't really talk about the TCAs either, did we, yesterday? The thing I want you to understand about the TCAs is they're very sedating. You remember 2 things. You remember 2 things. Severe orthostatic hypotension. So these really should be taken at nighttime. And these can cause urinary retention. Listen to what I'm telling you. The 2 big things about the TCAs are what?
Severe orthostatic.
See, because they're used to treat bedwetting in children. Why do you think they're used to treat bedwetting in children? Because, correct. That's amitriptyline, imipramine. Those are the big boys when it comes to the TCAs, the tricyclic antidepressants. Okay, imipramine is the one they usually use for the bedwetting. Okay, they also, okay, so I guess any one of those four, imipramine, doxepin, nortriptyline, and where's amitriptyline? Oh, amitriptyline. Those are the ones that I would really pay attention to that you're liable to see. Amitriptyline, imipramine, doxepin, and nortriptyline. We got that? A nursing aid. When it when it comes to the tricyclic antidepressants, because it can bottom out the blood pressure and cause them to fall, you want to make sure that they call for their nursing aid before they get out of bed. Do you understand that? N-aid, nursing aid. That's what we remember with the triptyline. So you don't trip. Call your what? And that'll help us remember. Okay? No, the meds. Nortriptyline, amitriptyline, imipramine, and doxepin. We got that? We got that? Come on now, get some. No, we ain't going nowhere. We ain't ready. We just cramming. We just, in the words of the late great, we just cramming. We ain't cramming. We're learning. We got to learn. We ain't got time to cram. We ain't got time to cram. We got time to cram. And TCA's got T in it for triptyline, doesn't it? It also has A for amitriptyline, doesn't it? So that puts it in short work order, doesn't it? Then all we need to remember is doxepin. And what's the other one? Huh? Imipramine. We got to remember imipramine. What do we got to remember? We got to remember doxepin. We got to remember amitriptyline, nortriptyline. Huh? If you trip, I nor the doc am responsible. Huh? I as in imipramine, nor as nortriptyline, am as in amitriptyline. We got that? What do you got to do? Do it. You want to do it the legitimate way? All right, everybody repeat after me. Imipramine. Say it. Doxepin. Amitriptyline. Nortriptyline. Very good. If you get it like that, that's fine. Whatever way you got to get it, guess what? You got to get it. You just use the curling iron or the flat iron.
I just took my braids out.
I like that. Okay? I'm with that. I like you too, Ronald. Huh? Oh, yeah. What did we do? Can we get some? Never. All right, let's try it. Y'all ready for another prioritization question? Are you ready for another prioritization question? A client with diabetic neuropathy reports a burning electrical type pain in the lower extremities that is worse at night and is not responding to the NSAIDs. What medication would be most beneficial for this patient? That's what I'm talking about. Attack. That's attacking. We don't even need the choices. Do you guys understand what GABA is? Let's talk about GABA. What is GABA? Gamma aminobutyric acid. Gamma aminobutyric acid. You don't need to remember that. It's a neurotransmitter that inhibits signals. Are you listening to me? We're talking about nerve impulses. I taught you the other day the two types of pain, didn't I? Did I teach you the two types of pain? Don't play. What were the two types of pain? Come on, guys. Seriously. Nociceptive, which is considered normal, that we're talking about right now. That we talking about right now. Neuropathic. Neuropathic, which we said is abnormal what? Impulses. Abnormal pain impulses. These are nervous impulses that are being abnormally released. Do you understand that? So until we stop the impulses, we can't stop the pain. We can't use the NSAIDs because the problem's not at the tissue level. The problem is from the brain and the spinal cord. We got to block the impulses. So that's where we go to the meds that suppress the nervous system transmission. And that's what Neurontin or gabapentin does. Do you understand that? It enhances that neurotransmitter to inhibit nervous impulses. So the nervous system can't keep sending inappropriate pain signals. Are you listening to me? Now, let's see if you would have got it right if I would have gave you the choices. Corticosteroids. Is that going to help with pain? That helps with what? Correct. But what's the downside of corticosteroids? Huge side effects. Huge side effects. They increase the blood sugar, don't they? They increase the blood pressure, don't they? They cause fluid retention, don't they? They drain the calcium out of the bones, don't they? They suppress the immune system and put you at risk for infection, don't they? Are you listening to me? So corticosteroids are the most effective for edema, but they can't be used, what? That long. Because of so many side effects. And they ain't going to do nothing for the what? Pain. Unless the pain is caused by the edema. What about hydromorphone? Dilaudid. Why don't we give them that? Is that going to work? Is that going to stop nervous impulses? No. Hydromorphone or an opioid is designed to land upon either mu or kappa receptors and enhance the natural opioids in the body. It doesn't block nervous impulses. Do you understand that? Lorazepam. Can we use lorazepam to stop the pain signals? No. It is not going to stop inappropriate pain signals. Do you understand that? The only one that's going to stop the inappropriate pain signals is what? The inhibitory neurotransmitter. Enhancing the inhibitory neurotransmitter, which is GABA-aminobutyric acid. Do we understand that? Pay attention. Do we understand that? Let's do another one. As the charge nurse, they're making you the charge nurse again. You are reviewing the charts of clients who were assigned to the care of a newly graduated RN. Ooh, that's you guys. The RN has correctly charted dose and time of medication, but there is no documentation regarding non-pharmaceutical measures. So no interventions prehand. What action should the nurse take? How do you handle this new RN?
Take them aside, explain to them.
Take me aside and explain it to me.
Make sure you document that you're trying.
Okay, that's negative. I don't want to hear that. I'm telling you how people going to respond to that. You came at me what? First thing you need to do, hey, I was checking out your charting. I noticed you really did good on documenting the dose and the time. How about you try? Do you understand that? The moral of the story is you want to start with what? Praise. You want to start with praise, especially a new RN. That new RN ain't going to know everything. Do you understand that? And you don't want to start it off with, hey, did you miss something in your charting? Do you hear me? Again, we learned in psych yesterday. What do people do when they hear something that they don't want to hear? What do they use? How do we take away the need to use a defense mechanism? Making them feel better, making them feel like you care about them. Do you understand that? You have to make them feel like you care about them, not like I'm just going to point out all your mistakes. Are you listening to me? I'm here, man. I'm going to stay on this side today. It says, give praise for correctly charting the dose and time and discuss the deficits in the charting. We got that? What's the first thing you want to do when you're trying to teach someone? And that includes the patient as well, doesn't it? Does that include the patient as well? What does Mr. Decker do to you all day long? Builds you up and breaks you down, doesn't he? He builds you up and breaks you down all day long, doesn't he? 1 minute he's looking at you like, you don't know this. Why can't we haven't learned this? What are we doing? And the other minute he's telling you how proud he is of you, that you can do it, how smart you are, etc. That's how you got to do it if you want people to listen to you. You can't just go in and just be like, well, we didn't do this, we didn't do that, we didn't do this, we didn't do that. Get to it. Because I'm going to be like, well, we didn't do this, we didn't do that, we didn't do this, we didn't do that. We don't need to get to it. But if you say we didn't do this, we didn't do that, we didn't do this, we didn't do that, but we need to do this and we need to do that because this is what we're going to get from it. I'm going to be more inclined to do what you want me to do. Are you listening to me? Okay. Now, let's get into a real scenario. Which client must be assigned to an experienced RN? Which client should be assigned to an experienced RN? I'm going to have to give you the choices on this one. And this is a SATA. Okay? This is a SATA. A client who was in an automobile crash and sustained multiple injuries. Should that be given to an experienced RN? Yeah, because it could be cervical or spinal involvement. Do you understand that? Client with chronic back pain related to a workplace injury. Chronic. It's already been diagnosed. It ain't going away. Should be pretty easy to what? Treat. Are you listening to me? A client who has returned from surgery and has a chest tube in place. Yes, what? Oh, experienced RN. All right. Experienced RN. You with me? Okay. A client with abdominal cramps related to food poisoning. No, standard treatment, right? Usually recover on their own. Not a big deal, right? Did you hear any symptoms that said they're going to die? Okay. A client with a severe headache of unknown origin. That's neuro. A client with chest pain who has a history of arteriosclerosis. Chest pain? MI? Are you listening to me? Acute coronary syndrome. Whoa, no, don't say it, Decker. Make them say it. Chest pain and a history of arteriosclerosis falls under the umbrella of what? Acute coronary syndrome. What does it fall under the umbrella of? Which is an MI. Are you listening to me? Didn't we go over that? Didn't I break down acute coronary syndrome? What are the three things that make up acute coronary syndrome? Unstable angina, arteriosclerosis, and an MI. Are you listening to me? Let me ask you a question. This ain't in here, but this is a question. If they describe to you a patient with chest pain, They describe, that's all they describe, and they said that you have a patient with chest pain, substernal chest pain. What do you give them? What do you give them? Correct. If they describe a patient with chest pain, and then they also describe that there's damage to the heart wall, what do? Send them to the cardiac cath lab. Correct. At that point, are you going to give nitro? It ain't going to do no good. Are you listening to me? If they've got a block or damage on that wall, that nitro ain't going to do jack. The nitro is for the vessels to dilate them. But if there's already a block, there's already damage, that nitro ain't going to do jack. Are you listening to me? You better watch out for that question. If it's just chest pain with no described damage, what are you going to do? If it's chest pain, but they are also describing that there's damage done inside the heart, what are we doing? Cath lab. Are you listening to me? All right. Let's talk about drugs for skin. Okay, what kind of drugs do we use on the skin? Topical drugs? How should you apply a topical drug? With gloves and what kind of layer? Thin. Very good. Thin layer, use gloves. We got that? What are the two most common bacterial infections of the skin? Staphylococcus aureus and Staphylococcus pyogenes. Staphylococcus aureus and Staphylococcus pyogenes. Do we understand that? You need to know that. What's the most common, two most common types of bacterium that affect the skin? Mm-hmm. Correct. So what are the common topical antibiotics that they can use? Bacitracin. Is bacitracin up there? Bacitracin up there? What about erythromycin ointment? Bacitracin, erythromycin ointment, gentamicin ointment, and metronidazole. What are the most common topical antibiotics? Bacitracin, erythromycin, gentamicin, and metronidazole. There's also mupirocin, neomycin, and tetracycline. The most common topical antibiotics are what? Bacitracin, erythromycin, gentamicin, metronidazole, mupirocin, neomycin, and tetracycline. You got to be familiar with these. Then it goes into tinea. It talks about tinea pedis. What drugs are we going to use to treat tinea pedis? Anything ends in zole. Z-O-L-E. Are you listening to me? Okay. All right, let's take a break. Oh, we better do this one. We're going to do lithium. We didn't do that yesterday. Lithium. We're going to do lithium. What? What email? What cohort are you in? I sent it to 41 and 42. Well, then come on up here. Come on up here. We're going to do this another kind of way. Okay? Type your email in there and then hit send. Here, let me get around. Oh, there you go. Right there. Click that and then just hit send. Right there. All right, then let me know if you got it, all right? Okay. That's easier. I didn't know I had you loaded in. I'd have did it myself. I didn't know.
not in the thing.
Oh, don't worry about it. Don't worry. Just keep reminding me. Okay. I'm taller than you. I'm short. Almost.
Wake up, Decker.
Yeah.
My son yesterday, the kindergarten roundup.
Man, you got you something there. That's the one that played the baseball.
Oh yeah, he had practice yesterday too.
You got something there. He loved the baseball, huh?
Yeah, he had practice like
He could probably hit it with
Oh,
it.
no.
Don't even need the tee, do he?
he hit it way out there. Look,
Can he
you
hit
gonna
it
see
without the tee?
Yeah,
If you just pitch it to him?
but he can't do it like that. You see how far he hit it? The coach way out there. Look,
Yeah.
you'll see the coach grabbing it right there.
Ah.
He had practice yesterday, but he
You know what? You know what they sell? They sell this 3-in-1 thing that you can buy that he can pitch through it. You put the ball in and it pops out. He can practice catching and he can bat in
I
it.
went and bought something from Five Below, but
Yeah.
I've been teaching them because my daughter, she's 7, so she plays soccer. I've been like, we go to the park and then we like catch and throw, and then I throw it at them underhand and
Yeah.
overhand and let them swing and just do it
You
like
know
that.
that's where the money's at. If you put him in a sport, you want him to go in baseball. That's where the money
I'm
is.
not really a big football person.
Yeah, ain't no money in
But he
football.
likes anything with ball. He likes basketball. He loves football.
But listen,
I'm gonna only let him play flag.
Ain't no money in football and basketball. The money's in baseball.
I'm only gonna let him play flag. But my daughter, she wants to play softball. She missed it because they were full. So I've been teaching her all the stuff. But that's all we do.
You know they're making $50 and $60 million a year in baseball.
Man, my son loves it. He like very advanced, but that's all his teachers, all his coaches
Yeah.
really be on him. But I told you he threw it up in the air until he caught it. That's
Yeah.
all he do in practice.
Make sure he works on that speed.
Oh, he fast.
He's really fast. He fast. Yeah, because he want to be a good base stealer in baseball.
Missed it up. When I tell you, he always been advanced. He started walking at like 9 months.
Yeah.
He was talking, but he is. So what made me put him in sports is because he'll get around people.
Yeah.
Every time he meets somebody, he'll be like, "You want to race? You want to race?
Ah.
I smoke you."
Ah.
That's how he talks. He be like, "Man, I smoke
Ah.
you." So look, this him too. And then I was.
Oh wow, he's an athlete.
Yeah.
He's natural, man.
He go get the ball. I gotta show you him racing these little boys at the park. Anybody, big kids,
He don't care.
no. He not scared. And that's the first thing he do when he meets somebody. He be like, "You want to race?
You want to
me?"
race?
Yeah. He like, "Come on, race me." He
Ah.
fast. That's all he want to do. The video. Man, you gonna be like, "Man, he's so fast," and he got a stride already.
Yeah.
It's what made me put him in sport. I was like, "Oh yeah, you gotta go in sport." He hilarious, man. He like so advanced.
That's
But it's
good for
scary.
him, though. That's good for him.
Video editing.
Once he sees the rewards he can get for excelling in sports, that'll really motivate him even more.
That's the point my daughter at.
But make him keep them books up too.
Okay,
Though.
so this him right here.
You make him keep the books up.
Yeah.
Oh, he looked at him. No, he didn't. Turn around and look at him. He took.
Mr. Decker, he like.
Oh, he's fast.
Man, I gotta bring him up here one day
Oh
so he
my
can
God!
meet
And
me.
he ain't even trying. He's
Look.
not even trying. Look what he does right off the line. He turns at him. Look.
And look his tongue out. Yeah. Now look at this one. He met them at this little park by
He
my
just
house.
said,
Like, let's
go.
race.
Oh, the guy in the yellow shirt. Nope. Bye. It's not even close. Look, he do got a little stride. Oh wow, he is fast.
And then it's him racing another little boy at the park.
Yeah, he got a little stance and everything. Bye. And that's a big kid, right? He beat the big kid.
And she started cheating. They raced like 5 times. He had everybody at the park, all the boys want to race. He was like, come on, let's race. And then started getting them race, and everybody was racing.
Everybody's racing.
Yeah. And this was when he was 4. He just turned 5.
That's crazy. That's crazy.
When he go up to the park, he'll get the bat.
Yeah.
He'll be like, Mom, no. Throw it underhand to me. He the one told me he didn't want the tee anymore. He was like, throw it underhand.
Yeah, he didn't look like he needed the tee. If he can catch like that, he don't need no tee. Hey, that's good though.
That's why.
He gonna be something. Mm-hmm. Hey. What? 120 questions. 120. Yeah, lunch. After we come back from lunch.
The 1 hour break is afterward we're gonna go home when we finish.
Because we have to. We can't go home too early.
Oh, so we still need to come back after the test?
After lunch.
So
yeah, and you need to come back after the test because I got to grade them.
Oh.
Okay? And the way I'll grade them is switch them around and have you grade them. I'll read out the answers. It'll be quick.
Oh, okay.
Yeah.
Oh, okay.
Yeah, paper test.
All right, at least
It ain't going to be that bad. Stop sweating it.
I'm not sweating it. It's just Friday.
I know.
I like it.
I was thinking of it.
But I can't leave but so early. That's why we're taking lunch at 12. You'll get back at 1. You take the test and be out of here by 2 something.
That's good if you will tell Dancer Mr. Decker after the test. So
I will. Yeah, and you can't take them home though because I need them. You know what I'm saying? I need them because she's got to. I don't know what she does with them, but she's got to have them.
Because that's part of the.
It's like proof that we're doing it.
Yeah,
Right. Okay. Oh, we got to do this.
How many classes is it?
What you mean?
And it's like a physical therapy class.
Oh, you mean how many class? They got a PT class. They got a MA class. I don't know when that started. They got a PN class and they got the RN class. It's like four or five. Maybe there's another one I don't know about. I know about the MA, the PT, the LPN, and the RN. Usually it's 4 at graduation. All right, pay attention. Did everybody sign in?
Oh no, I didn't. I didn't see it when I came. I didn't want to interrupt. I was already late.
What? What? You didn't sign it? Just email Ms. Coons. Yeah. All right, pay attention. Pay attention. Time to shut it all down. Okay? What's the first meds that we learned today? Benzodiazepines? How do we remember? Don't be looking at the papers. Come on now. This is just when you come back from studying. Listen, pay attention to what we're doing here. When you go study and then you leave the studying and then you take your break and you come back, the first thing you want to do is a recall. What did I remember? And if you didn't remember enough, then that means you shouldn't go on. You need to go back. Okay, so the cold part, CCCOLD, how many of the meds out of that do we remember? That's the that's just a reminder, the CCCOLD. Chlordioxyperoxide. Clonazepam. No. Let's deal with the C's first. We got to get these C's down. Clonazepam, chlordioxyperoxide, and what was the third C? Clorazepate. Very good. So we got the C's. Now what's the O? Huh? Olazepam. What was the L? Lorazepam. Y'all said that quick. And what was the D? There you go. It's not that hard. And you do this all day long. It only takes a second to do the recall before you progress. You can't study something and study something and study something and study something and try to recall it all. It ain't going to work. You don't got to be perfect. You don't got to be able to recite it 100%. But if you can't tell me nothing about it, what's the use of remembering CCCOLD? It don't tell you nothing. Are you listening to me? Pay attention. Come on now. Turn it up. So now we can identify a benzodiazepine, which is good. What was that unique side effect that they said that it causes? Retrograde amnesia. See, there it is. Retrograde amnesia. And that should make sense because they use midazolam during the surgical procedures. It causes what? It causes what? And then an adverse effect that it could cause, you learned it could cause the exact opposite effect, which is called what? Paradoxical. Paradoxical. What kind of response is the opposite response of what the med is intended? Listen to me. Pay attention. Okay? Pay attention. And then we also got to worry about two organs while they're on that benzodiazepine. What are those two organs? And then the third, bam. Bam, man. Should we be paying attention to that urinary output? Should we be paying attention to the respiratory rate? Should we be paying attention to the blood pressure? That's where they're going to come at you because that's dangerous. Do you understand that? What's the longest time you should be on that benzo? What's the antidote? Look at these guys. See what I'm saying? Guys, that was on my NCLEX. The antidote to benzodiazepine was on my NCLEX. The antidote to mag sulfate was on my NCLEX. What was the next medication class that we went over? Well, we put the three level. No, you're good. We got the 3-level order for the anti-epileptic meds. What is it? Benzos. What do you got to worry about? What do you got to remember with the phenytoin? So they need frequent mouth care? And they interact with other meds, especially what? Anticoagulants. And then what's the worst of the worst? Barbiturates. What was the other meds that we talked about? Trazodone. What is the name of the condition? A priapism, tomato. Huh? Right. Yeah. Just remember, usually when a male wakes up in the morning, the first thing he's got to do is what? Pee. Okay? So priapism. Because they have that regular morning, yeah. Okay? Pre-pism. That's it. All right, what is that? What else did we talk about? Well, briefly. TCAs. What does TCA stand for? What are the two things that I said that you better remember about them? Orthostatic hypotension and urinary retention. Do we understand that? And if you have a choice when to give it at what? Because they're at risk for what? And it'll cause dry mouth too, guys. It'll cause dry mouth too, guys. It'll cause blurred vision too, guys. It'll cause constipation too, guys. It has that anticholinergic effect, guys. That ain't bad. If you didn't peep at your notes and you answered, that's not bad for a one-time through. For a quick one-time through, that's not bad. And imagine if you did it through every day through the course of your study. A quick. We ain't got time to be digging. Quick. What do I remember? Okay? What else did we talk about? Huh? Gabapentin. Very good. Specifically used to treat what kind of pain? Neuropathic pain. Neuropathic pain. Abnormal pain response. Oh, GABA. But I want you to understand something about gabapentin. It can cause convulsions and seizures. What could gabapentin cause? Tremors, convulsions, seizures. If you see that in your patient, the dose may be too high. Are you listening to me? And it can suppress, so it can suppress those vital organs. What are we talking about, vital organs? Lung, heart, right? All right, now yesterday we didn't talk about lithium, and we need to talk about lithium because that's a mood stabilizer used to treat what? And the manic part of bipolar. Lithium carbonate. Okay, look what it says. This thing is hard on the GI tract. Lithium is hard on the what? And it can cause what? In the hands. Fine hand tremors. This can interfere with purposeful motor skills and be exacerbated by stress and caffeine. What? Also, the P's. There's the P's that go with lithium. You're going to pee a lot, you're going to poop a lot. You're going to pee a lot, you're going to poop a lot. When you take lithium, what are you going to do? So that could lead to dehydration, couldn't it? You're going to gain weight. It can damage the kidneys. And it can mess with the thyroid, guys. It can cause a goiter and hypothyroidism from taking lithium. Okay, also bradydysrhythmias, hypotension, and electrolyte imbalances. Now, you need to remember the normal range of lithium. It's the same as the creatinine, 0.6 to 1.2. Do we understand that? A half a dozen to a dozen. 6 to 12. Okay? And look what happens when you get too much lithium. What electrolyte is associated with this toxicity? Sodium. When the sodium is low, the lithium becomes toxic. Okay? It says here, if the lithium level stays below 1.5, manifestations are going to be diarrhea, nausea, vomiting, thirst, polyuria, muscle weakness, fine hand tremors, slurred speech, and lethargy. But if that thing gets between 1.5 and 2.0, you're going to have major GI distress, which includes nausea, vomiting, and diarrhea. It's going to affect mental status, causing confusion, poor coordination, coarse tremors, and sedation. Look, fine. It starts out with fine, and as the toxicity progresses, it converts to what? Coarse tremors. We got that? Once the levels reach 2 0.0 to 2.5. And guys, I sent you this. You got this. Okay? They'll have extreme polyuria of dilute urine. The ears will start ringing. Tinnitus. They'll have involuntary extremity movements with blurred vision, ataxia, and eventually what? Now pay attention. That's not hard to remember. If the lithium is toxic, where's the sodium? What did we learn about sodium? Low or high sodium puts you at risk for what? Okay? So when you're looking at this, you're looking at the symptoms that mirror hyponatremia. Are you listening to me? Okay? This can lead to death from respiratory complications, severe hypotension, and death from respiratory complications. And they say if that lithium level reaches greater than 2.5, you ain't going to be peeing, you're going to have seizures, and you're going to go into a coma and die. 2.5, the patient's not going to be alive. Do you understand that? It's a pregnancy category D. So the only way we would possibly give this med is to prevent the patient from what? Which is, there's not a case. There's not a case for that. Okay? Use cautiously in older adult clients who have thyroid disease, because it said, what does it do to the thyroid? Goiter, hypo. Goiter, hypo. Lithium causes the thyroid to overwork. It doesn't have the proper iodine, so instead it hypertrophies, causing the goiter, and it loses its functional ability. Are you paying attention? Okay? So, nursing intervention. You need to obtain a lithium level with each dose change, which can be 1 to 2 times a week initially. It's hard to get this thing balanced. It's hard to get this thing balanced at first. Once a therapeutic level is obtained, monthly monitoring can occur, then every 2 to 3 months after a period of stability. Okay, when should you collect the lithium blood levels? In the morning, 10 to 12 hours after the last dose. Okay? Anything that puts the patient at risk for dehydration puts them at risk for what? Do we understand that? I already did the insights of God. See them? Remember them guys? Who was it? Who is this? Hal. Okay. How? He caught the what? Because there wasn't no what? Where's that chlorine? There was no chlorine in the pool, right? You can see there's other ones too now. Thioxine, there's perfenazine, there's loxapine, trifluperazine. But the most common ones are the ones you need to focus on. Okay? The what do we, hold up, I'm getting. The haloperidol, chlorpromazine, and flufenazine. You better at least know them. And the what is it? Doxa what? What is it? No, it's not doxa. It's what? Thiothioxine. It's what? Perfenazine. It's what? Trifluoperazine, if you want to be that person. The loxapine, if you want to be that person. Because I could change the whole story and say Hal had dreadlocks, didn't he? Hal had dreadlocks. Hal had locks, and he tried to not get the flu. He tried to not get the flu, right? But he got into a pool that didn't have any chlorine. And how do I know this? Per Theo. That's who reported it. You see that? I can extend that story. We can do that. See these extrapyramidal side effects we were talking about yesterday? Are these side effects or adverse effects? Side effect. They're going to happen. And you got to know the different types. What is dystonia? Dystonia. What does that mean? Okay, it's where they basically lock up. The muscles lock up. They get very, very rigid and lock up. Okay? Parkinson's. We talked about that because of the depletion of what? Dopamine. Akathisia. You can't sit. Did you watch my video last night? Did you see the akathisia? Where the person can't sit still or having them involuntary movements. Okay? What about tardive dyskinesia? Okay? What about neuroleptic malignant syndrome? Do we remember that? Serotonin syndrome, neuroleptic malignant syndrome. Give me 2 telltale signs. Excellent. All right, so then we get into this anticholinergic. So what we going to do, hold on, where are we at? Anticholinergics. I can't harp on this enough. I don't want to get on the board and start doing all that and doing all that. It's time for you to understand. I'm going to try to make this as simple as I can for you. There's one main neurotransmitter. There's one main neurotransmitter that the brain uses to innervate the organs. There's one main neurotransmitter. It's called acetylcholine. Are you listening to me? There's one main neurotransmitter that the brain uses to innervate the organs. What's the name of it? This acetylcholine, when it's released from the brain, has 2 pathways that it can travel based on the autonomic response. It can either go through the sympathetic pathway or the parasympathetic pathway. If it goes through the sympathetic pathway, it's not going to remain as acetylcholine. It's going to get to a certain point and then activate the release of epinephrine, norepinephrine, and dopamine. But it starts the pathway as what chemical? Do you understand that? The sympathetic, you learn, is ran by dopamine, epinephrine, and norepinephrine. But what is the precursor to the release of those chemicals? Now, on the parasympathetic side, it stays acetylcholine the whole time. Do you understand that? It stays acetylcholine the whole time. It doesn't need to stimulate other chemicals like it does on the sympathetic side. I'll try to teach you something that will help you over here if you understand that dopamine, epinephrine, and norepinephrine are the same thing with just added ingredients. It is all dopamine. Dopamine with additional chemicals either becomes norepinephrine or epinephrine. Do you understand that? It's the acetylcholine that stimulates their release. You're following a pathway. Hold on a minute. You're following a pathway. This electricity is following a pathway. Do you understand that? So in this example, this would be the brain, and it's sending orders down this nerve pathway. And this pathway bifurcates. And it's got a choice. I can either go over here or I can go over here. So you think of over here as the sympathetic effect when we need to fight or flight. And you think over here is the parasympathetic effect when we need to rest or digest. So this acetylcholine needs to change on one of these 2 sides. It can't be the same for both sides because it'll cause the same effect for both sides. We need opposite effects. Do we understand that? So if it goes towards the sympathetic side, it's going to be the precursor for the release of these catecholamines. Do you understand that? The dopamine, the epinephrine, and the norepinephrine. So we can execute fight or flight response symptoms. If it goes through the parasympathetic pathway, it's going to operate the rest and digest functions. Do you understand that? Acetylcholine is referred to as a cholinergic. What is acetylcholine referred to as? Acetylcholine, when it stays acetylcholine, is referred to as a what? Acetylcholine, when it stays acetylcholine, is referred to as a what? What part of the digestive tract do you actually release poop from? The colon. And when you're releasing that poop from the colon, what must you do in order to get the feces out? Take a seat. You remember acetylcholine. Do you understand that? Because it's that acetylcholine that lets you have that bowel movement. It's that acetylcholine that allows you to pee. But it's not called acetylcholine. It's called a cholinergic. Because the poop comes out of your what? Colon. Are you listening to me? Acetylcholine is you got to know that going in. That's a hard thing to remember, isn't it? Acetylcholine in medications is referred to as a what? It's not referred to as acetylcholine. It's referred to as a cholinergic. It's referred to as a cholinergic. Are you listening to me? So when we give a cholinergic, which part of the autonomic nervous system is it working for? The parasympathetic, which means it's going to have what two major kind of actions? Resting and digesting. Resting and digesting. Right now, your cholinergic receptors are activated. Right now. May I? I momentarily stimulated his sympathetic nervous system. But once he realized, oh, that's that little teeny pipsqueak Decker, he went right back into parasympathetic mode. Do you understand that? So for a second, he almost had release of catecholamines. If his arm would have extended and grabbed my shirt, you know that the catecholamine was activated. But instead, he chose to rest and digest, so you know that he's just releasing acetylcholine, which is a in order to oppose the parasympathetic nervous system, you've got to cancel out the acetylcholine. But again, we don't refer to it as acetylcholine. We refer to it as a what? So you give an anticholinergic. You give an anticholinergic to cancel out cholinergic activity, which means you're canceling out what chemical? Acetylcholine is used by what part of the autonomic nervous system? The parasympathetic's goal is to do two main things. What is that? Do you understand what's included with that? What does the heart rate need to do when you're resting and digesting? What does the blood sugar need to do when you're resting and digesting? What does the blood pressure need to do when you're resting and digesting? What do your pupils need to do when you're resting and digesting? So you can read. So you can read. How you going to read right now if you ain't chilling? Yesterday with the fire trucks and the police and the gas and all that, your pupils got wide, didn't they? Because you was looking for an exit. But when you're trying to focus and you're resting and digesting, you want your pupils to do what? When you're in danger, you want them to do what? It ain't no different in your house. In your house, you got one little reading light. You also have a big, gigantic light. If the bad guys are in your house, which one do you want on? The gigantic light. When you're reading, which one do you want on? Which means smaller amount of light. You don't need that much light if it's right in front of you. But when you're in danger, you want all the light you can get, right? Which extends your vision. Are you listening to me? The bronchioles, do we need them to dilate when we're chilling? So what do the bronchioles do when you're sitting there chilling? Are you listening to me? This is the things that the cholinergic or acetylcholine does for you. Can I pee when I'm resting and digesting? Can I digest when I'm resting and digesting? That's all thanks to acetylcholine in the form of a... When we cancel out this activity, we give them an anticholinergic. Do you understand that? When we cancel out this activity, we give them a what? So what is an anticholinergic going to do to the pupil? When you dilate the pupil, it prevents the drainage of aqueous humor. When you dilate the pupils, it disrupts the drainage of what fluid in the anterior chamber of the eye. When you dilate the pupils, what fluid has a hard time of draining out in your eye? What condition does a patient have when they have a problem draining the fluid out of the anterior chamber of their eye? So you would never want to give what kind of med to a patient with glaucoma. And you also learned the benzodiazepine today either, right? Didn't it say contraindicated for patients with glaucoma? Pay attention. This is a highly tested, dangerous issue that we're talking about right now. You never give an anticholinergic to what type of patient? Because what is it going to do to the pupils? And when you dilate the pupil, what does this prevent? Drainage of the aqueous humor. Do we understand that? You got to know that. That's the type of test question you could see on that NCLEX because it's dangerous. It's dangerous for you to go, he's having a reaction, let's give him a little diphenhydramine. And his intraocular pressure is skyrocketed. Do you know diphenhydramine is an anticholinergic? Do psych patients take anticholinergic to help with the EPS? Benzotropine's an anticholinergic, isn't it? You got to know, atropine's the biggest anticholinergic, right? Don't we go get eye procedures that give us the atropine to dilate the pupil so they can see in the eye better? Would you give atropine to a glaucoma patient? No. Would you give diphenhydramine to a glaucoma patient? Would you give a benzodiazepine to a glaucoma patient? You got to know that going to NCLEX. You got to know that when you walk into where? Because they going to test you on something like that. They want to see if you're a safe nurse or a dangerous nurse. What are you, a safe nurse or a dangerous nurse? Oh, I ain't hear much confidence with that. Now, let's talk about this here. Look what it says. Examples of the meds that are considered anticholinergics. Examples of the meds. Your tricyclic antidepressants are what? It says it on the slide, guys. Oxybutynin. What is oxybutynin? Oxybutynin, what is that? An antispasmodic for the bladder. It prevents bladder spasms. Oxybutynin, what is that? Okay. Toliteridine. All these meds here. Sulfenacin. They are all antimuscarinic used to treat overactive bladder. Okay. What about dicyclamine? That's for the GI tract, right? Spasms in the GI tract. What is dicyclamine? Come on, God. No. Unacceptable. Foul flag. Throw a flag. Offsides. Defense. 5-yard penalty. Repeat first down. Okay. Very good. Okay. Scopolamine. Highly tested. Scopolamine. Highly tested. Scopolamine for motion sickness. Correct. Scopolamine for what? Scopolamine for what? But it's also a what? Anticholinergic. It's usually a patch that you have to apply. Behind the ear. How long? When? 30 minutes before? 30 minutes before? Okay. 4 hours. Who said 4 hours? It might. I don't know. I heard 30 minutes last time I checked. Okay. I might be wrong. Okay. Don't take my word for it. When do you replace this? Every 72 hours you have to replace it. It's an antiemetic used for motion sickness. Also controls secretions. What do they mean by that? Secretions. Salivation, right? Excessive salivation. Lacrimation, right? Lacrimation. Okay? Any type of secretions. Says make sure whenever you put on a patch, this applies to all patches, that you put it where? Where? Behind the ear. When do you apply it? When do you replace it? Okay? And then what do you do when you're done? Then what do you do? All right. Huh? What? Put what in the trash? Oh. All right. When you're folding them patches, make sure you're folding the insides together. Do you understand that? And you don't touch them, especially the fentanyl patches. And make sure you don't put that in the trash. And make sure you have somebody witness the disposal of that fentanyl patch. Are you listening to me? Guys, make sure you get everybody. Don't be Mrs. A-line. Don't be A-line. Don't go out there being A-line. Do you understand that? Don't go out there being that person. Don't be abbreviating stuff and walking around with your stethoscope around your neck thinking you're cool. You should never put your stethoscope around your neck. Do you understand that? That's disrespectful. Don't put your stethoscope around your neck. Roll it up, put it in your pocket like you're supposed to. Ain't nobody want to see that wearing around your neck. Because most of the time, the people to be wearing around their neck, that's where it stays. Do you understand that? That ain't a necklace. Put it in your pocket. Have some dignity about you. Do you understand that? When you see the bosses, the big boys come in, where they got their stethoscope? Because they know a little something. Do you understand that? When they holding the stethoscope, how they holding the stethoscope? How they holding that stethoscope? Who's got a stethoscope? Nobody got a stethoscope? Let me teach you something. No, it ain't old Lord, it's old Decker. Hey. First of all, and I'm not even trying to be silly, I have to ask this question because a lot of people don't know that. What is this called? The diaphragm. What is this called? What is this called? What is this called? What is this called? Do we understand that? Which one's bigger? High pitched. Which one's smaller? Low pitched. Are you listening to me? Which is this called? What's this called? What kind of sounds? What kind of sounds? Firm pressure. Light pressure. Firm pressure. Light pressure. Do you understand that? When you're using the diaphragm, what kind of pressure? When you're using the bell, what kind of pressure? Okay? Now, when you're auscultating heart valve sounds, you never put these two fingers on this stethoscope. Do you understand that? Or you're going to hear your own pulse. You hold this stethoscope like this. If you can't hold it like this because of positioning, then you hold the tubing. But you do not put these two, and if you can't do that, then you use these fingers. Do you understand that? Same thing applies when you're palpating a pulse. You never use these two fingers, period. Are you listening to me? You want to be exact? You want to be right? You want to do it the right way? Don't use these two fingers. Are you listening to me? And you know you got to turn the thing on, right? Okay? Thank you. Okay? And if you ever use somebody's stethoscope, what do you need to do before you use it? You should be doing it on your own. Clean the earpieces or you're going to get a nasty ear infection. And they might not even have an ear infection. It's just you're exchanging their flora into your ear, introducing their flora into your ear. You might get a what? A nasty ear infection. Okay? And what do you need to be doing anyway after you be using it on your patient? And what do you need to do before you put it on your patient? Warm it up. Warm that thing up. Don't put that cold thing on my skin. Okay? What are we talking about? Anticholinergics. There we go. All right, so we were talking about anticholinergics. Do we get it? Are we going to walk out of this classroom and I stop you at the door and I say, wait a minute. What type of patient do you not give an anticholinergic to? What are the 4 main symptoms of an anticholinergic? Blurred vision, constipation, urinary retention. Dry it up. Dry it up and tie it up. Do you understand that? What would an anticholinergic do? And tie it up. It'll dry it up and tie it up. What is constipation? That's tying it up, ain't it? Urinary retention, what's that? Tying it up. We got that? What will an anticholinergic do? Don't give it to a patient with what? What are the 2 types of glaucoma? Come on, get in there. Get in there. Get it. Come on, you want to race? You remember that mentality. He got that mentality already. You want to race? Okay? That's my new saying now. Thank you for that. There's this little kid already, athlete. First thing he does when he gets to the park is what? You want to race. You see that? He's got that in him. That's that stuff. That's that special magic. That's that go get it thing. That's something you usually got to inherit, but it can be transferred. It can be modeled. But usually you got to inherit that gene. That go get it gene. You got the go get it gene? That's what you got to do. Go get it because it ain't coming to you. Do you understand that? You got to go get it. Okay? You got to go get it. So again, anticholinergics, big boys. The biggest of the big boys is the atropine. Atropine. Do we understand that? What's the biggest anticholinergic we need to remember? Atropine. Everybody bow to atropine. Because you're going to learn that in your advanced cardiac life support. And when you take ACLS, you're going to learn about old atropine. That's what you give first for symptomatic bradycardia. Because who is it? Pay attention, learn something, big boy. If that heart rate is dropping and it's symptomatic, meaning the body's producing symptoms similar to that drop, we know what part of the autonomic nervous system is causing that drop. Parasympathetic. What chemical is it using to do it? In the form of a cholinergic. So what are you going to give them? An anticholinergic, such as atropine, to prevent the parasympathetic from doing what to the heart rate. Now, if you give that anticholinergic and it doesn't work, what does that tell you? It's not the parasympathetic. Now you need to give a sympathetic stimulant, such as epinephrine. Are you listening to me? That's big boy stuff. Do you understand that? That's big boy stuff. You got to know big boy stuff. You understand atropine for the glaucoma, but now you understand atropine for that heart rate as well, don't you? Okay? So when you're giving atropine, what do you think you need to check? Ha ha ha. Ha ha ha. See that? You see that? So, what do we got? When it comes to anticholinergics, you see benzotropine up there? You know that's the drug they give for the EPS, right? You see scopolamine up there? What bed is that? Come on, get in the party. Atropine, what are we talking about here? It can increase the heart rate. What else? But what do we know about atropine? They use it all the time for what? Eye exams. They use it all the time to dry up secretions before surgeries. Are you listening to me? Okay. What about dicyclamine? Where are we at? GI. Dicyclamine, where are we at? Oxybutynin, where are we at? Benzotropine, where are we at? EPS. Scopolamine, where are we at? Taking a trip. Atropine, where are we at? At the eye doctor. Okay. Dicyclamine, where are we at? Dinner. Okay. Oxybutynin, where are we at? In the bathroom. Let's do it again. Benzotropine, where are we at? Scopolamine, what we about to do? Atropine, where are we at? Dicyclamine, where are we at? Oxybutynin, where are we at? Look at that. Look at that. Rest and digest. Rest and digest. We use that on itself. We use that on itself. Are you listening to me? Besides the benzotropine, we took a trip. Ain't that resting? Isn't that resting when you take a trip? Supposed to be. What is it supposed to be when you take a trip? When we went to the eye doctors, we took a what? A rest. Okay? One of the biggest reasons you can't go to any of those places because you got to do what? Work. Okay? When we took the dicyclamine, where'd we go? Dinner. Now we digesting, right? And after we digest, we got to excrete with the what? The oxybutynin. Pay attention. Pay attention. When it comes to anticholinergics, what are we talking about? I ain't worrying about all that. I'm worried about you being able to identify it right now. I'm worried about you being able to identify an anticholinergic. Atropine, dicyclamine, oxybutynin, scopolamine, diphenhydramine. Come on. Huh? Benzotropin. All right, come on. Get these. Grab these. Stab these. Get these.
They give it in the mouth as well.
Yeah, we said that. Yeah, to dry up secretions before surgical procedures. Okay? Oh, oral, whatever. Okay. That's good to know. What?
A lot of hospice patients.
They give atropine. Well, they give the scopolamine too. They give all kinds of meds to dry up secretions, but it doesn't matter what the med name is. It matters what the class it's in. What is the class? And you need to be able to identify the med because they're not going to tell you what class it's from. Are you listening to me? They ain't going to tell you on the test. They're going to say the nurse receives a new order for scopolamine. What nursing interventions apply? Do we understand that? Should they be operating heavy machinery while they're on scopolamine? Should they be drinking alcohol while they're on scopolamine? Do you understand that? Should you be checking your heart rate when you're on scopolamine? So that's the types of stuff that they're going to ask you. I want to know that you can identify a drug when you get in that NCLEX and know what it is. That's what's most important for me in the farm today. Do you understand that? We ain't getting into the normal side effect, headache and all that, nausea and vomiting and all that kind of stuff. You just remember that almost every med can cause a headache, nausea and vomiting and GI distress. Do you understand that? You want the unique things about the med that could kill the patient. That's where they're going to come at you on NCLEX. What about this could kill the patient? That's why the antipsychotics are very important because of the neuroleptic malignant syndrome. And you can suspect a question on one of those because of that. Okay? So do we have our anticholinergics down pat? NCLEX is? Oh, it causes photosensitivity. Okay. Photosensitivity. Okay. Most anticholinergics do cause photosensitivity or sensitivity to light. Why? No. What are they doing to the pupil? So they're letting more what in? Do you understand that? Most all anticholinergics cause what? Photosensitivity. Because they're letting more light into the eye. Does everybody understand that? Okay? Anything that dilates the pupil can cause photosensitivity. Okay? All right, we got those? All right, what time is it? It's almost break. Yeah, let's take a break. When we come back, you know what we're going to do. Hold on, let me slide away. I'm sliding. You sliding? I'm sliding. Hey, I ain't that first thing I heard you say the whole boot camp. Huh? And where your lollipop at? Usually you got your little lollipop going.
If I may.
Huh? And I didn't know she was here. You can't. Oh, welcome. I'm glad you could make it. I'm messing with her. I'm messing with her. She knows I know that. Huh? I can hear you. What?
My phone be catching it though.
Catching what?
My responses.
Oh, you recording it. Can you play it back for me so I can see what you said? Yeah. No, I'm just playing. I am so happy I don't have to teach tonight or tomorrow night. Oh, who's the speaker? Miss Coons wants to know who's y'all's speaker for graduation. Huh? Judith for the day?
Tiffany for the night.
Judith. Hold up. Judith for day. Hold up. What's Judith's last name? Johnson. Johnson for day. And Tiffany Riley for night?
She figures it. No, it's I think me and Brittany are both.
Ronald and Brittany? Okay, that would make a good combination. Ronald and Brittany Farr.
Tell Tiffany you sent her.
Yeah, let's. Okay, Judith Johnson for day, Ronald and Brittany Farr for nights. Okay, I had to say Farr because we got a lot of Brittany's. Okay. Dang, that's going to be something, man, because Judith doesn't really talk. Yeah, but she doesn't really talk in class. I bet, but I want to hear her talk because I don't hardly hear her talk. Ronald will be a good, I'm sure that'll be hilarious. That's going to be hilarious. Ronald, I don't really think you care. I think you'll find a way to pull it off. Hilarious. Are we learning?
Yes, sir.
Is it helping?
It is.
Good.
Last night I went home and I did my pre-assessment baddie, and a lot of stuff we've been going over was on that. So I got a 90 on it.
Awesome. Can you let people know that? Let them know that.
Yeah, no, well, Tamika's been very vocal too.
Yeah. But I want to, as many as I can, to get them to understand.
That's why I was waiting to finish greenlighting because I wanted to do this.
Yeah.
Because I figured it would help me on this. So.
And it's gonna.
Yeah.
Watch what I tell you. Watch what I tell you. You green light yet, Letitia?
Have I green light yet?
Yeah.
No, I still got maternal.
That's it?
Maternal, and I'm waiting on her to decide on leadership. I finished.
What do you mean?
everything. She haven't completed it yet. Like.
Okay, but you've done it and all that. Okay, keep bugging her. Send her an email every day.
Okay.
Every day. And look, after like the third one, CC Miss Coons in it.
Okay.
I'd see Sawira every time. That's just what I do.
Has that been a problem?
Always.
Okay.
You got to stay on her.
Okay.
Stay
So I
on
need
her.
to email her then,
Yeah,
because
every
she's kinda
day.
slow about writing
Yeah,
all
if
of
you
my
lay
stuff.
back, she'll lay back.
Oh, so maybe
Yeah, like
yeah. I
yeah.
be trying to be patient. But I
No,
but,
that's still being patient.
yeah.
But you
No, but if she's
you trying to do big things, and that's what they paying for, that service to get you ready for NCLEX. So why would they make you wait?
That's true. And I was looking at her responses
Yeah.
from what I, from what I, how you put in your response, and like her response, she like put correct on all of mine, but the rationale that's sent is nothing like what I commented. You get what I'm saying? So it's not telling me where I'm wrong at, and it's not completely right. So how is it correct? You know what I mean? So
So she's not really giving a crap.
No.
You need to tell that stuff to Miss Coons, because
I read that last
they
night.
paying for that
Yeah.
service,
And I
man.
let her know.
Yeah, please
I didn't know
do.
that was a thing, but I was like, she said correct, but this ain't nothing compared to the rationale.
So you're not learning from it.
Right.
And
You're
that's
telling me I'm right, but I'm not right.
right. And I'm glad you're honest enough to admit that.
Yeah.
I'm gonna let Miss Coons know that too as well.
I didn't know that was right.
You got this though.
Tell them the way.
What? What? Miss Coons asked me who's speaking. I went ahead. Ronald said you're speaking.
Ron will speak.
See, that's why I can't stand
He told me he's joking.
I know I told him, I ain't doing that.
You make an excellent speaker.
Who, Mr. Ron?
No, you.
No, Mr.
Yeah.
Ron should do it.
Oh no, it'll be funny. Ronald, yeah, it'll be fun. Him and Brittany are doing it
Oh, they are?
together.
Okay.
So that'll be cool. That'll be like, they'll get you up.
Yeah. Yeah, he gonna do something.
But Tiffany, I think you would do well too. And you.
No.
Yeah, I can see this. You get the whole posse doing that. Hi, Miss Coons.
I actually did, like when I was in high school, I could have been salutatorian, and I was actually the salutatorian to speak,
Yeah.
but I didn't.
When I was in LPN, I was supposed to be the top grade, but I don't want.
Stay back here.
Yeah, yeah.
I just want to walk across.
Like when they came in the other day with a certificate. Oh, that's embarrassing. Because that brings the heat. You know what I mean?
And I just have a question. You said that yesterday you had your mic on and you were talking to a lady.
Isn't that
Like you said lady, and I was like, is he married?
Listen.
No, we didn't. You could have said that. I ain't have no conversation.
Listen, Mr. Deck ain't doing nothing he ain't supposed to be doing. Put it like that. Okay? Mr. Deck ain't doing nothing he ain't supposed to be doing. Yeah. All right, pay attention. Pay attention. Pay attention. Pay attention. Pay attention. What med did we talk about before we took this break? Lithium carbonate. First med we talked about when we came back was what? And that's a big boy on the NCLEX. We can't afford to miss lithium carbonate. That's your psych. That might be your psych. Your easy, well, I'd call that mid-grade. Probably be a mid-grade question on lithium. Okay? What are they going to be doing a lot of it when they're taking lithium? Peeing, pooping, and they're going to be thirsty, right? Because they're going to be losing all that what? Fluid and sodium, right? And we can't afford to lose that sodium because if we lose the sodium, the lithium's going to what? It's going to go toxic. Okay? And once that lithium level exceeds what number, they're going to start having these symptoms. 1.5. And then by the time it gets to what? 2.5, they're not alive. Are you listening to me? We can't afford to miss out on that lithium. Are we missing out on that lithium? We can't afford to miss out on that what? We need to go back to the lithium because guess what? We didn't study. Okay, we didn't get that. We didn't get that trophy. Okay, where are we at? Right here, right? What is the hallmark of toxicity? Fine ham tremors. And then fine ham tremors are going to progress to what? Coarse ham tremors. If we don't remember nothing else about lithium, we remember the sign that indicates toxicity, which starts out as and progresses to. Do we understand that? What electrolyte do we need to pay special attention to in regards to this toxicity?
Sorry. I need one evening class speaker, not two. So just get out. Ronald, you're in.
Ronald.
Brittany, forego her nomination.
You could come up there and stand, Brian. All right.
Congratulations, Ron.
Hold on.
And what about Judith? We got to give class speaker. I'm going to make sure I come to that one. Huh? I'm coming to that graduation. Huh? I'm coming to that graduation. I promise you that. I want to hear Judith Johnson speak. Okay, I want to hear. Can I ask y'all test questions? Oh. All right, come on, let's go through this lithium again. We ain't got enough. Look what it says it does. Listen, look, come on. What does it do? Lithium produces neurochemical changes in the brain. So it basically blocks what chemical? Serotonin. Now we got to stop for a second. We got to do some research. Everybody look up serotonin. Serotonin. A natural chemical, a neurotransmitter and hormone that plays a role in bodily functions, which include what? Mood regulation. So stop. Taking lithium could affect the what? Sleep. Taking lithium could prevent what? Appetite. Taking lithium could cause what? Anorexia. Okay? And it can affect what? Digestion. And right off the gate, they told us it was hard on the GI system, didn't they? They tell us it causes GI distress because serotonin is referred to as the what? You sure your name ain't serotonin? The happy chemical. The happy chemical. Okay? Due to its contribution to feelings of well-being. It affects digestion, blood clotting. What? It affects blood clotting. What does serotonin affect? And wound healing. So if you taking lithium, you might not get these benefits. Do we understand that? Okay? Let's get back up here. Where are we at? Complications. The number one that it said is what? GI distress. And they're going to be doing a lot of what we said? Peeing and pooping. And when it starts to get toxic, they're going to exhibit what? And these can cause problems with motor skills, right? And they can be enhanced by anything that excites the nervous system, which includes what and what? Stress and caffeine. polyuria, mild thirst. It can cause weight gain, renal toxicity, and the big boy, the thyroid. The big boy, which is the what? The thyroid. Lithium can affect what gland? So lithium can affect metabolism. Lithium can affect what? Okay? Once they become toxic, diarrhea, nausea, vomiting, thirst, polyuria, muscle weakness, and then the fine hand tremors, the slurred speech, and lethargy. Okay? So once it's 1.5 to 2, still having that GI distress, but now we're going to have nausea, vomiting, diarrhea, mental confusion, poor coordination, and the hallmark. Once it gets 2 to 2.5, except now we don't have coarse hand tremors, we have what? Coarse hand tremors. Instead of fine hand tremors, we have what? And then once it gets to 2.5, what do we got? What category, pregnancy category is lithium? That means you don't get it and give it unless what? And because it can affect the thyroid, don't you got to use caution if you're giving it to somebody with a thyroid or a seizure disorder or somebody that has diabetes? Are you paying attention? And it interacts with several drugs. The diuretics because of the sodium loss. The NSAIDs because the increase of this will cause renal reabsorption of lithium leading to toxicity. Don't take NSAIDs with what? Lithium. Don't take lithium with what? NSAIDs. And then the anticholinergics, antihistamines, tricyclic antidepressants can induce urinary retention and polyuria leading to abdominal discomfort. We got that? You want to get those lithium levels frequently? You want them using salt substitutes and things of that nature? They're going to have to increase things in their diet too, right? What are they going to have to increase in the diet? Potassium. If they're peeing a lot, what are they losing? You got to keep an eye on that potassium too, don't you? Got to keep an eye on that sodium too, don't you? Because if they lose the sodium, what's going to happen? Toxic, 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 toxic. What is gabapentin?
Neuropathic pain.
Used for neuropathic pain? Do we know carbamazepine and all these guys? Lamotrigine? These are also used for seizures. Look, lamotrigine. I want to teach you one. Lamotrigine. Do the research. What is the safest anti-epileptic drug for a pregnant woman? Lamotrigine. What is the most safest anti-epileptic drug for a pregnant woman? Lamotrigine. Huh? And look at carbamazepine. Look, I want you to remember something about carbamazepine. It can cause blood dyscrasias. Look what it says. If they got bone marrow suppression, you don't want to use this because carbamazepine could suppress your cells, red blood cells, white blood cells, platelets. Carbamazepine. Blood dyscrasias. What does carbamazepine cause? Okay? You can't drink what? You don't teach a patient to drink grapefruit juice with anything. Okay? What can decrease the effects of carbamazepine? Your hydantoins and your barbiturates. Okay? Lamotrigine. We got that? We got that? We got that? I'm going to do like my toddler. We got that? We got that? We got that? We got that? Huh? Oh, no, he don't, boy. Oh, Papa, 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 until I answer him.
Sometimes when you do answer,
But he could be sitting right beside me. I'm watching a movie. I just fixed his toy. Last night I want Sonic on my Switch. So I bought him the Sonic. First I had to, because you'll buy him a game, he'll play with it for 3 seconds, and that's it. So I said, if I get you this game, you're going to play. Yes, Papa. Yes, Papa. He got all excited and all that when it got the thing. I'm sitting there trying to watch a show. He's sitting right beside me playing on the Stitch. And he looks at me and goes, Papa, 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 Papa. I'm right in the middle of trying to hear what I'm trying to hear. I like, little baby, wait a minute. I'm listening. Papa, 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 Papa. I said, Jay, what? I don't know how to jump this. I don't play video. Let me see the thing. So I get the thing, get him to where he's got to get, give him the thing back. 3 seconds later, Papa, 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 Papa. I figured him out. It's not about him not understanding how to play the game. He wants my attention and wants me to play the game with him. So I had to take the little rubber sword and we had to have a sword fight. But he don't like to lose. If you start, like, he'll give you a toy. Like he told me to pick. I picked King Kong. He picked Scar King. Okay? I like King Kong. And I was like, oh, you can't mess with King Kong. And I hit him. And now he goes, I want King Kong. You take the Scar King. All right. Don't forget that clozapine, guys. Don't forget that clozapine, guys. Do we understand that? Okay? What do you got to check with the clozapine? CBCs. CBC. 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 Okay. Do we know what bupropion is? Wellbutrin? Yeah. Do we know what that's used for? All right. Is that the one that reduces the seizure threshold, though? Hold on a minute. You know, all these psychotic drugs cause suicidal ideation. Yeah. Look at this. Bupropion increases seizure risk because it lowers the seizure threshold. You got to know that. Okay? Bupropion does what? Risk for seizures. Okay? Huh? You own this. I sent this to you. Okay? You own this. What? You own this. I gave you this same thing here. I know what you try. You try to get it done now, so you ain't got to study later.
No, not only that, but you know, when you send stuff and you writing it down, when she probably go back through it, she probably not going to.
If you pulled it up in your computer right now, there's this little thing that'll highlight it for you. Do you know what I'm saying? There's this thing on your computer where you can just highlight it. Did y'all know that? You can swipe the line and turn it a certain color.
A lot of times the way that you say it makes more sense than what it
That's
was
what I was
written.
just trying to.
So I write it down the way you say it to make more sense.
And that's why I told you to bring a what?
Order.
Guys, and I'm not even trying to be fancy. We got a lot of material to go through. I can't go but so slow.
Is that going to be available to us?
Yeah, I'm imagining. After they edit it all out, they're supposed to put it up there. That's what it's for. I don't know how long it's going to take because it's the first time they've ever done it and they got to edit it. But as far as I'm concerned, yeah. But come on, man. You can't bring a little recording device up in this camp? Who's in here recording it? Would it be a pain in the butt to send that to everybody? Oh, huh? Edit my what? They probably should edit that.
It's gonna make it interesting.
Not if you weren't there. You'd be like, man, he talked too much. No, he does it too much. Yeah, he does it too much. I've listened to his lecture. He's good, but he needs to stop so much with the, you know what I mean? The Trump style, the stroke his ego thing. He needs to cut that out. And you can hear it when he talk. Oh, I know I'm the crap, and you're gonna come anyway. So I got your $500. So sit down and shut up. That's his attitude. Yeah. But look, that man had been around. He done made some money. I wish we could have a competition. Let's race. Let's race. I want that money. Shoot, if I could get that position and do that, sure. I make that money. If they gave me that opportunity, I beat them. I beat them. I beat them. I get that money. All right, come on, y'all. They got to edit all that out too right now. All right, listen. Let's go over our. Oh yeah, I forgot to tell you. Ooh, y'all gonna be mad. I got something I got to do today. We got to take lunch at 12. I got something I got to do. Yeah, tomorrow. What? Down a little bit. The what? You talking about this? No. The tricyclic antidepressants? That's where I'm rolling downward. I started up top and I'm rolling downward. Yeah. All right, let's leave it right here. All right, let's go over our herbal supplements real quick. What do we know about aloe? What is aloe used for? This should be quick, fast, and burns. Skin is good for the skin, right? Okay, what's the side effect? It'll make you poop because it has a laxative effect. Okay? Okay, they use it for weight loss as well. I don't see that up here, but maybe they do. Okay, it's good for inflammation. Okay, what about black cohosh, guys? Black cohosh. Yeah, because it mimics estrogen. Black cohosh mimics what? Do we understand that? But it can bottom out your blood sugar. Black cohosh can do what? Okay. It also increases the effects of antihypertensive meds. It shouldn't be used more than 6 months, and it should not be taken in the first 2 trimesters of pregnancy. That black cohosh. Okay. It mimics what? Estrogen. What about it? I know some of the people in here are gonna get it because I don't know how to say this really well, but the echinacea. I think I said it close. Echinacea. Okay, that's for the immune system. Very good. Okay, but remember, it can cause an allergic reaction because it does help the immune system. Any med that affects the immune system can cause a what? Do you understand that? Including what? Echinacea, a herbal supplement. You got to know that. What about Fever View? What do you need to know about that? That's used to treat migraines. Okay, but what do you need to know about it? Huh? Yeah, why? Right. All the G's, Fever View and chamomile have the same thing in common. What do all the G's, Fever View and chamomile have in common? Do you understand that? Anything that starts with G. Okay? Ginger root, does that start with G? Ginkgo biloba, does that start with G? Ginger, does that start with G? Garlic, does that start with G? All of those can make you what? What do they take ginkgo biloba for? Mental, right? Memory. It also vasodilator. Okay. What about garlic? What is that good for? Cholesterol. Okay. Cholesterol, cardiac, heart. What about St. John's wort? Saw palmetto. Prostate. Listen, that's highly tested. Saul Palmetto. Prostate. Prostate. Okay. Cranberry helps with what? UTIs. Soy helps with what? Symptoms of menopause. Symptoms of menopause. Prevents cardiovascular disease and cancer. What about flaxseed? Laxative or cholesterol? Laxative or cholesterol? What about turmeric? Turmeric or turmeric. How do you say that? That's indigestion and reduces inflammation. What about elderberry? Cold symptoms, correct. Green tea? Whole bunch of things. Antioxidant, cholesterol, cancer prevention, GI symptoms. What about stevia? Stevia, that's a natural sweetener. Okay? You got to know these herbal supplements. You teach the patient never take them without telling who. Does natural mean safe?
No.
Okay. All right, what do we need to know about iron supplements? What do they help with first? What is iron given for? So red blood cells and hemoglobin, right? What is iron necessary for? Very good. Okay. So they are used to treat what conditions? Anemia. Very good. Okay. How well is iron absorbed by the body when taken orally? Not well. So you need to take it on what kind of stomach? Because if you take it with food, that'll make the absorption even worse. Do you understand that? Because it's not absorbed well. You don't want to take it with what? What enhances the absorption? Excellent. If it's liquid iron, what's the issue? Okay. Okay, use a straw, it can stain the teeth. What do we need to know about giving it to children? When you're giving it to a child, it can cause iron toxicity. Do you understand that? Very quickly. Now, how do you treat any kind of metal disorder in the body? Isn't iron a metal? So whenever you have high metal in the body, lead, iron, etc., what is the name of the therapy that they use? Chelation therapy. When you see chelation therapy, what are they trying to do? Get something out of your body that's in excess. Do you understand that? And usually it's a metal. Are you listening to me? Chelation therapy. Okay. What happens to the stool? Constipation, and it turns to what color? What do you teach the patient? What do you teach the patient about the black tarry stool? Can you please go get the registered nurse? What do you teach the patient about the black tarry stool?
Oh, it's blood, right?
It's normal as long as you have no abdominal distension or pain. You need to understand something right now. Don't write nothing down. Look up here. Because the stool is now black and tarry, we have no way to identify a bleed. So the only way that we have to identify a possible bleed now is if they have distension or pain. You never tell a patient anything is what? Are you listening to me? Because they're going to take that to the bank. Oh, I'm normal. I can go do whatever the heck I want to do. They said I'm normal. No, they said that's normal, but you don't even want to go there so they don't get it confused. Are you listening to me? And you got to have some kind of identifiable way to tell the patient to come back in because there could be a possible problem. And what's going to cover your bottom? What's going to cover your bottom? Telling the patient that dark tarry stools are normal, or telling the patient dark tarry stools are normal finding as long as you don't have any abdominal pain or distension. Because could you see the one, and that's all it takes, that has that extreme abdominal distension and pain, but goes, but I'm normal, but I'm normal, but I'm normal, and has a complication? Whose fault is that? Whose fault is that? The nurse. So what do we teach about the black tarry stool? It's a normal finding. It's not even that it's normal. Don't even word it like that. It's a usual normal finding. Might not apply to you when I word it like that. Are you listening to me? If we just say it's normal, then that applies to everybody. Do you understand that? That's a usual normal finding. However, if you have any abdominal distension or pain, you need to come back and see us, which means you don't apply to that usual normal finding. Are you paying attention? And when you document that you educated the patient, that's exactly the way you want to document it. That you educated the patient that this was a usual normal finding, as long as, do you understand that? You want to cover your butt so when you get pulled into court, that lawyer don't rip you apart. Didn't you tell the patient that a dark tarry stools are normal? Did you tell the patient that? Did you tell the patient any signs or symptoms to come back in for? Not related to that dark tarry stool, did you? If it was related to the dark tarry stool, you told them they were cool. Now you're sitting in the courtroom looking like a... You should have paid attention when you were in... Got them bars, boy. Does iron also stain the skin?
Yes.
Is iron a vesicant?
Yes.
So what method, when we're giving iron injections, do we use? What are good dietary sources of iron? Specifically? Liver? Liver. That's a good one. Okay, what about eggs? Egg yolk. Egg yolk. Egg yolk. Okay, good sources of iron. And if you ever forget, you think of that vegetarian. What are they usually deficient in? Iron. Why are they usually deficient in iron? Because they don't eat a lot of what? Vitamin A. What's the other name? What are the two names? Retinol and? Which one's the safe one? When you think of vitamin A, what do you think of? Night vision. Very good. Vitamin D. What's the importance? The absorption of calcium and phosphorus. Vitamin E. What do you think of? Immune support. Antioxidant. B1. What is it? Vitamin B1. What is the name? What condition can result from a lack of vitamin B1? Or Wernicke's-Korsakoff syndrome. Everybody look up Wernicke's-Korsakoff. Wernicke-Korsakoff. Wernicke's-Korsakoff. Look it up. And while you're doing that, what's vitamin B2? Riboflavin. What is vitamin B3? Niacin. What's vitamin B6? Pyridoxine. What's vitamin B9? Huh? Okay, pantothenic acid. What is vitamin B12? Which vitamin deficiency causes pellagra? Own it, boy. We own it. We own it. What is Wernicke's-Korsakoff's?
neurological disorder primarily caused by deficiency of vitamin B1, thiamine. Often results from chronic alcohol abuse, but can also occur due to other nutritional deficiencies or medical conditions. Two distinct phases: Wernicke's encephalopathy and Korsakoff syndrome.
Korsakoff is the psychosis. Do you understand that? The Wernicke's, brain damage, which leads to Korsakoff's, which is what? Psychosis. Okay? Everybody got that?
The Wernicke's is acute.
And Korsakoff's is the chronic. Wernicke's is the what? And Korsakoff's is the what? Korsakoff's is the what? Wernicke's is the what? What vitamin are we talking about? What's the name of it? What condition are we talking about? Which is a form of beriberi, right? Which one? The wet or dry? The wet is about what? The heart. Look at these guys. These guys are starting to sound like registered nurses. These guys are starting to sound like what? Huh? What are y'all starting to sound like? What are the 4 properties necessary for red blood cell and iron production? Protein, folic acid, iron, B12. Was that you? Was that you? B's. You could say the B's because B6 and B12. Just the B's, but very good. Good Lord, man. Are we growing? Are we growing? Or are we showing? Or are we slowing? All right. Emeron, cytoxin, Emberel, methotrexate, Cellcept, Rapamune, Prograf, which is Tacnol. So you can't do this. Why did they do this? Null and void. Scratch that. They mix in brands with generics. You can't. There will be no brand names on the NCLEX. Scratch that. That's lazy. All right, let's talk about this alpha-2 adrenergic agonist real quick. Alpha-2. Look, I tried to teach you all this before. I'm going to try to teach you simply again. When it comes to the sympathetic nervous system, there are 2 main types of receptors. There's more than 2, but 2 by letter. You have alpha receptor and beta receptor. You have alpha receptor and beta receptor. And even though there's 3 set receptors under beta, meaning beta 1, 2, and 3, you only got to remember 2. Beta 1, beta 2. And all you got to remember under alpha is alpha 1, alpha 2. And I really would like to get you to nail this, because this is going to help you tremendously if you understand this concept. Again, what part of the autonomic nervous system are we referring to? And the sympathetic operates that what? So we know that now we're talking about receptors that activate the body for this fight or flight mode, right? And they can be found in various parts of your body. And according to where they're found is according to how they're labeled. Whether they're alpha 1, alpha 2, beta 1, beta 2. Do you understand that? Does everybody understand that? Does everybody understand that? You got to understand that part. The why is there an alpha 1, alpha 2, beta 1, beta 2? Because they're all different. Are you listening to me? So when you think of an alpha 1 receptor, alpha 1, all I want you to remember, when the sympathetic sends a chemical to this alpha 1 receptor, the blood vessels are going to constrict. Alpha 1 receptors do what? Constrict blood vessels. What is that going to do to the blood pressure? So when they're talking about medications, You just remember your terms, agonist and antagonist. So if they say you're giving an alpha 1 receptor antagonist, what are you doing? Blocking the receptor. So instead of getting vasoconstriction, you're going to get what? Instead of getting vasoconstriction, you're going to get what? Because you block that receptor. Dilation. A alpha 1 antagonist will block alpha 1. So therefore, instead of the sympathetic being able to constrict those blood vessels will do what instead? Does everybody in here understand that? Does everybody in here understand that? Now understand this. Alpha 2 receptors, all that is a shutoff valve. Alpha 2 receptor is a shutoff valve, meaning after the sympathetic nervous system has made its actions known and it's no longer needed, a signal is sent to alpha 2 to shut it off. Are you listening to me? So if you give an alpha 2 agonist, who are you shutting off? Sympathetic effect, which is going to do what? Blood pressure. And the vessels are going to what? Dilate. Are you listening to me? Get this money. This is free money. If you know what happens at the alpha 1 receptor, game over. What happens at alpha 1 receptors? Vasoconstriction. If you block that receptor, what's going to happen? At the alpha 2 receptor, what happens? Shutoff valve for the sympathetic nervous system. If you give an alpha 2 agonist, you're speeding up that shutoff. Are you listening to me? And that's the way some of these meds are named. And you'll know by the name what's it doing. An alpha 2 adrenergic agonist. It's shutting down adrenaline. Do you understand that? It sounds like it's increasing it, doesn't it? Alpha 2 adrenergic agonist, but it's doing it at what receptor? And alpha 2 is an inhibitory receptor. Are you listening to me? So that's why that med there, clonidine, can be given for blood pressure. Because what it's doing is shutting off who? Are you listening to me? This is the key to the game, guys. This is the key to the BMW. Somebody just flipped you the keys and said, go take a ride. This is the cheat code to that. So when you see that on the test, you don't get dumbfounded and go, alpha 2 adrenergic agonist, what the heck are they doing here? Immediately, alpha 2 shutting down sympathetic. Because I know it, because what kind of med am I giving? An agonist, something that intensifies the effect at that receptor. And I know alpha 2 is the shutoff valve. Are you listening to me? Alpha 1 increases sympathetic effects. Alpha 2 stops sympathetic effects. Alpha 1 turns the light on. Alpha 2 turns the light off. Alpha 1 turns the light on. Alpha 2 does what? So I want to antagonize the light to shut it off, and I want to agonize it to turn it off, depending on what receptor I'm at. Do you understand that? If I give an alpha 1 antagonist, I'm blocking the vasoconstriction, and instead I'll get vasodilation. If I give an alpha 2 agonist, I'm speeding up the shutoff valve. See how they're opposites, but you're doing the same thing? With an alpha 1, you're antagonizing. With an alpha 2, you're agonizing. But you're still shutting it down. Because this is the on switch and this is the off switch. You want to prevent the on switch and promote the off switch. Are you listening to me? Know this, learn this, lock this down. Understand this. So when they use those terms on the test, alpha 2 adrenergic, Whatever's coming after that, you know what you're doing to it. You're agonizing an alpha 2 receptor. You're speeding up the what? The shutoff. You're speeding up the what? Everybody got that? An alpha 1 agonist. An alpha 1 antagonist. What are you doing? Vasodilation, preventing vasoconstriction. Are you paying attention? Okay? Activates the presynaptic alpha 2 adrenergic receptors within the brain. This is going to lead to sedation, drowsiness, and fatigue because you're shutting everything what? Down. You're dilating those blood vessels. What happens to the blood pressure? You're slowing the heart rate. What happens to the heart rate? What receptor did I just do according to what I just taught you? Alpha 2. Alpha 2. That's an alpha 2 move. Just shut it all down. Do you understand that? But I got to use what kind of med to do that? I'm not blocking it. I'm encouraging it. Y'all want that on? Okay. We don't need it. Who said we should shut it off, though? Was it? Oh, okay. OCD. All right, when should we not give this med? Look what it says. You can't give clonidine to a child younger than 6. You can't give clonidine to who? Most fat does interferes. Okay. And then it just jumps to right there. Okay, we'll do that in a second. Hold on. Let's do some of these. In application of the principles of pain treatment, what is the first consideration? In application of the principles of pain treatment, what is the first consideration? This is going to make you go, oh. What's the first thing they teach you about pain? Say it loud and proud. The client's perception of pain must be accepted first. In the priority, read the question again. In application of the principles of pain treatment, what is the first thing that you should consider? The patient's perception of their pain. Are you paying attention? That's an easy question, isn't it? Maybe, maybe not. What did they put it up against? Treatment is based on the client's goals. A multidisciplinary approach is needed. Drug side effects must be prevented and managed. Does that sound like we centered the patient in this at all? We focused on whose responsibilities? Ours. When the first thing we should acknowledge is who? And their perception of pain. Even if Ronald's laughing and giggling and watching TV, if he tells me he's in severe pain, then I take his word for it. Do you understand that? Because I don't know how he endures pain. Some people are very stoic about it, aren't they? Does it mean he's not in pain just because he's not guarding and showing signs of pain? So again, pain is always what the patient says it is. Do you understand that? Okay, that was an easy question. When an analgesic is titrated to manage pain, what is the priority goal with titration? Why do we titrate? What is the purpose? Huh? None of those are wrong answers, but come on, open your minds.
I want to see how they're responding.
You want to use the lowest possible dose to produce a therapeutic effect to keep the side and adverse effects down. You want to use the lowest possible dose that produces a therapeutic effect while keeping the side and adverse effects down. Are you listening to me? What is the goal of titration? Use the lowest possible dose to produce a therapeutic effect. You got to put that part in there. To produce, you got to produce a what? But you want to use the lowest possible dose to do that, and also lowering the side and adverse effects. Do you understand that? That is the purpose of titration. Is titration a one-way thing? Do we only go up? We also go down. Okay? For client education about non-pharmaceutical alternatives, which topic could you delegate to an experienced LPN who will function with your continued support and supervision? 1. Therapeutic touch. 2. Application of heat and cold. 3. Meditation. Or 4. Transcutaneous electrical nerve stimulation. Which one of those is appropriate to delegate to the LPN with your supervision? Which is one of those is only an application and it doesn't require teaching and it doesn't require proper technique? Hot and cold therapy, correct. You do not want them doing therapeutic touch. They don't have the skill or training to do therapeutic touch. Therapeutic touch doesn't just mean, can I touch? Therapeutic touch. They're talking about percussion. They're talking about the cupping with the therapeutic touch. They don't have the training or education necessary for the therapeutic touch. And it requires them to educate the patient. But just applying a hot or a cold application would be the same thing as just handing over a med or doing a simple dressing change. Do you understand that? It doesn't require much abstract thought. Do we understand that? It's something very concrete and basic, and it said that you could even oversee that. Do you want them doing meditation with the patient? Are they trained to do that with the patient? Do you want them to do transcutaneous nerve stimulation with the patient? I know a lot of y'all LPNs are getting offended, but put it away. You're about to be an RN in a few weeks. Okay? I was an LPN myself. I used to get offended at first, but now I realize I was ridiculous for getting offended. Because I didn't know nowhere near what I was supposed to know. Do you understand that? You guys do now, but it's not because you're PNs, it's because you're RN students about to be RNs. Are you listening to me? You did the work and you probably worked really hard and really well. But now you got the knowledge to go along with the work. Okay? So if you're offended by the way that they apply these things, then you're going to get the questions wrong. Do you get that? I didn't write the question. They're writing the questions. They're the ones making the PNs look a little non-abstract. Not me. A client received as an as-needed PRN, morphine, lorazepam, and cyclobenzapine. Let's break this down. Morphine is an opioid, right? Lorazepam is a benzodiazepine, right? Cyclobenzapine is a muscle relaxer, right? What is cyclobenzapine? Do you understand that? That's a centrally acting muscle relaxer, right? The UAP reports that the client has a respiratory rate of 10. What is the priority action? What's the priority action? I'm going to read it one more time. Silence, please. A client received, as needed, morphine, lorazepam, and cyclobenzaprine. The UAP reports that the client has a respiratory rate of 10. Correct. First thing you're going to do is say thank you, and then you're going to go verify that anything that they just said is true. So you're going to need to do an assessment. Do you understand that? Can you take the UAP's word? Thanks, Chief. Let me go grab the naloxone and the flumazine. No. I need to go in there and assess that patient myself. Do we understand that? Okay? Let me tell you something. Unfortunately, you can't trust anybody, but especially not most of the time the UAPs. Because a lot of times UAPs are lazy and they don't understand how important those vital signs are, and they're not actually taking those vital signs. They're making them up. They're literally just putting numbers down on the paper and bringing it back to you and saying, here, I did this 10 or 15 vital signs I was supposed to do. And that is a fact. And you'll even know it if you continuously look at all the ones that they keep bringing to you, because they'll usually be the same, if not close. Do you understand that? They don't want to take the time to go in there, or they don't want to wake the patient up, so they'll just write an erroneous number down there and tell you that's what they got. And that's a fact, guys. That happens all the time. So just because somebody comes and tells you a problem as an RN, the first thing you need to do is what? Assess. Which client is at greatest risk for respiratory depression while receiving opioids for analgesia? Which client is at greatest risk for respiratory depression while receiving opioids for analgesia? An elder client with chronic pain who has a hip fracture. An elder client with chronic pain who has a hip fracture. A client with a heroin addiction and back pain. A client with a heroin addiction and back pain. A young female client with advanced multiple myeloma, or a child with arm fracture and cystic fibrosis. Which client is at greatest risk for respiratory depression while receiving an opioid? An elder client with chronic pain who has a hip fracture, a client with a heroin addiction and back pain, a young female client with advanced multiple myeloma, or a child who has an arm fracture and cystic fibrosis. Where are they going at with this? Where are they going at? There's more than one patient in there that it's at risk for respiratory depression, isn't there? But there's one in there that has multiple risks. Who had the multiple risks? One's got an age problem and a respiratory issue. Who's got the age problem and the respiratory issue? The child. The child's too what? Young, and they have cystic fibrosis, which affects the what? The elder adult, it said that that's an issue, older age, okay? But they have chronic pain and a hip fracture. That's not a respiratory condition. Do we understand that? Remember that word I taught you the other day called naive? Opioid naive? Who's opioid naive? The child. The child's an opioid naive. Are they used to opioids? They're a child. So they're automatically what? Opioid naive. And they got a respiratory condition, cystic fibrosis. Who's most at risk? See what they do? They don't tell you that some of them could have multiple risk factors. They just put patients in there, and you got to pull out which ones has the multiple factors. You see that? I like that color. You see that? What?
Not Brittany blushing today. You like her hair?
I like your ombre. Whoever sits in the front row, I can see. Everybody else, I probably can't even see that far away. Okay? Build them up, break them down, right? Huh?
What was your question? I'm sorry, sir.
Guys, we're not in the questions, are we? We're not doing well on these. We're not paying attention to these. We got to get into these. Huh? It's 11:11.
Make a wish.
11:11. Can we finish this? Can we finish this a little stronger? Can we pull up the sleeves? Put on the boots. Come on now. Let's get this next one. A client is crying and grimacing. If you got to and you can't keep up with me, make little notes. Crying, grimacing. So far, all I've said is a patient is what? But denies pain and refuses pain medications because my sibling is a drug addict and has ruined our lives. What is the priority intervention for this client? What is the priority for this patient? Educate them? Hold on a minute. I don't care what you're feeling. I need to teach you something right now. Allow them to express their fears and concerns. No, that is not part of the education. That's the part where you shut up and listen. Do you understand that? Listen to me. When a person is in distress, they're not right off the door trying to hear you tell them how not to be in distress. Sometimes you need to allow them to do what? Get it out. Let me assess. Do you understand all you're doing by allowing them to express themselves is assessing them? Like when you was a little kid and they was playing double dutch in the street and you're waiting for the exact opportunity to get in there. You can't just get in there right off the gate, can you? You got to stand back for a second and watch and listen. So all you're doing here is the first thing that a nurse does before they make a move, which is what? Assess. And what you're assessing is what's important to them. Any misconceptions that they may make. And then you can teach them about those misconceptions or those fears. But again, the first thing a nurse does is what? And you see how they did that? They transformed that. You got to think about what assessment includes. Sometimes it's sitting there silent, observing. Do you understand that? But you're still assessing, right? Let me see if I can figure out the problem. So tell me exactly what's wrong. What are your concerns? What are your concerns? I'm going to wind up just like my... Well, what were the circumstances? Why were they taking those meds? Let's get to the bottom of the thing. Let's assess it all the way out. Try to look for our opportunity, right? We're looking for our opportunity. You got that? You got to think of it like that. Sometimes you ain't the big dog. Who's the big dog? The patient's the big dog. Do you understand that? Sometimes you the big dog, sometimes the patient's the big dog. Encourage expression of fears and past experiences. Now look at the choices. Provide accurate information about the use of pain meds. Education. Explain that addiction is unlikely among acute care clients. Education. Seek family assistance in resolving this problem. Lazy. What's the first thing you do as a registered nurse? Assess. That's a broad term, isn't it? And you use broad terms all the time. That's why I make you get into the details so you can start understanding. You got to look past the broad statements. You got to get in there and swim around. Okay? I bet you won't get that kind of question wrong again, won't you? Because the first thing you should be shooting in your head is, do I need to do what here? Is there enough information in that question to make a move? Read the question again, Decker. A client is crying and grimacing but denies pain and refuses the pain medication and makes one statement. My sibling is a drug addict and has ruined our life. Is that enough information to make a move? No. That's not enough information to make a move. So if there's not enough information in the question to make a move, you need to what? Assess. Are you listening to me? A client's opioid therapy is being tapered off, and the nurse is watchful for signs of withdrawal. I'm going to get you. I'm going to get you. I bet you I get you. I bet you I get you because I taught you. Watch what I taught you and watch what I get you. A client's opioid therapy is being tapered off, and the nurse is watchful for signs of withdrawal. What is one of the first signs of withdrawal? Oh, I didn't get you. I didn't get them two. Who said it? What's the medical term, though? Don't get too big of a head. Diaphoresis. Very good. Who else said it? Who's the other one? I heard two people. That's it. 2 out of how many in this class? $24. 2 out of 24. I did get you. I did get you. You need to remember that. What's the first question you ask somebody that's a drinker? And what's the first symptom you need to be looking for? And the second symptom you need to be looking for? What are you trying to avoid? What are you trying to avoid? Tremors. Who said that? You don't wait to try to avoid what? Seizures. You don't wait to try to prevent what? You try to prevent what? Because tremors is the precursor to what? Once tremors start, we convert it from withdrawal to what? Delirium tremens. Once we see tremors, what state are we in? If we just see diaphoresis, that's just what? Do we understand that? Ain't nobody going to know that. Ain't nobody out there know that. Everybody going to tell you the number one sign is what? Because their assessment techniques are terrible and they're not looking for the diaphoresis or asking the right questions. Are you listening to me? What are you looking for? Diaphoresis. What are you hoping you don't see? Because you know if you see the hand tremors, what could happen at any moment? We got that? It says, in the care of clients with pain and discomfort, which task is most appropriate to delegate to the UAP? It says, in the care of clients with pain and discomfort, which task is most appropriate to delegate to the UAP? Assisting the client with preparation of a cyst bath, monitoring the client for signs of discomfort while ambulating, coaching the client to deep breathe during painful procedures, or evaluating relief after applying a cold compress. Cyst bath? What was the key word? Assisting. What was the key word? Should they be monitoring? Should they be coaching? Should they be evaluating? So this question was answered by the first word. Do you understand that? The physician has ordered a placebo for a client with chronic pain. You are a newly hired nurse and you feel very uncomfortable administering the medication. What is the first action that you should take? First of all, what is a placebo? What is a placebo? You guys don't know what a placebo is. Doesn't have to be fake.
Something that
Non-therapeutic. Doesn't have to be a fake pill. Could be a real pill. It's just not going to provide any therapeutic effect. And they know that when they prescribe it. Could be a regular med, but the dose is so low that it's not going to provide what? A therapeutic effect. Do we understand that? Is that unethical to give a patient a placebo? It interferes with the ethical principle of what? Veracity. Because you're not telling the what? Do we understand that? So what do you do? What do you do? Correct. Who do you go to? Go to the supervisor. You contact the supervisor. And the supervisor should advocate for you. Do you understand that? Okay? Go to the supervisor. Put it in the supervisor's hands. But don't give it if you know it's a placebo. Do you understand that? Once you hand it over to the supervisor, you're not the one that's in trouble here. Do you understand that? If you just not give it and don't tell nobody, now you're in murky water. Because you better be definitively right that that's a placebo. Do you understand that? You better be definitively right that's a placebo. That's why they advise you to take it to the supervisor and let them figure all that out. Do you understand that? If you don't know it's a placebo, then no, you can't get in trouble. You can't get in trouble if you don't know it's a placebo, because you're not going to know every dose. And like I said, it could be a regular medication. Okay? But you'll know in the event if it's given for pain and it's not working, you need to do your research. Look up the standard dose of that med. Do your homework. So what they're trying to tell you is protect your patient. Do you understand that? You know your patient's in extreme pain and you receive this order for this med that doesn't normally treat that kind of pain and it's in a very low dose. Do your research. Do your research. For a cognitively impaired client who cannot accurately report pain, what is the first action that you should take? For a cognitively impaired client who cannot accurately report pain, what is the first action that you should take? Obtain baseline behavioral indicators from the family. That's when you want to involve the family. If they're cognitively impaired, they're not going to be their own power of attorney anyway. So you can ask the family. How do you guys know when he's in pain? What kind of signals are given? Okay? You want to ask the family. It might not be the standard things. Do we understand that? They'll be able to tell you and direct you. Put that down for a while. All right, let's go into these medications to support withdrawal and abstinence from alcohol. Somebody was asking me about this yesterday. They wanted to learn this. Who was that? All right, remain anonymous. All right. Remember, the first question you want to ask is when you had your last drink. Remember, them withdrawal symptoms can start as early as how long? 4 hours. And they can last and continue for how long?
Every 7 days.
And then alcohol withdrawal delirium can occur 2 to 3 days after stopping alcohol, and that is a medical emergency. So the first line treatment is your benzodiazepines because they prevent those seizures. Do you understand that? Okay, and the antidote to benzodiazepines is what? Now, what you got to remember about this flumazenil and what you got to remember about this naloxone is if you have to give them as an antidote, you have to understand not only are you going to decrease the level of toxicity, but you're going to reverse the process of the med. So if they were taking an opioid for pain, the pain's going to immediately come back. If they were taking the benzo to prevent seizures, then what is possible that they could have as soon as you give this antidote? And you need to be prepared for that. Do you understand that? When you give that antidote. Okay?
So, are they giving the benzos like, so the patient decide they want to stop drinking like cold turkey, whatever? Are they?
No, they're giving them the benzo to suppress the nervous system to prevent the
Okay,
seizures.
so you're not giving it to them until they're in withdrawal.
No, you're gonna give them to them anytime you suspect that they're possibly going into seizures, delirium tremens. You might not necessarily give them for withdrawal. Depends on their anxiety level. You'll know by their anxiety. Are they anxious? Are they irritable? Then you want to calm the central nervous system down. Do you understand that? Because that's when that withdrawal can flip into delirium tremens. Okay? All right, so it says here, they give this beta blocker propanolol. Listen it. They give this beta blocker propanolol, and they give that for tachycardia. Listen to what I'm teaching you here. They give that usually when you have any condition like a thyroid condition or any condition that causes the heart rate to elevate, they're going to give them a beta blocker. And that beta blocker is going to decrease the heart rate. But you got to check the pulse before you give it. Okay? When we get into the beta blockers, the first question I'm going to ask you, like I did with the mental health, with the restraints, what are the two types of restraints? I'm going to ask you, what are the two types of beta blockers? That's what I'm going to ask you. And why am I going to ask you that? Okay, which one affects only the heart? Okay, so beta 1, so selective is what we call it. We call them cardioselective. Okay, not beta 1, because they both affect beta 1. The other one just affects beta 1 and beta 2. Okay, that's non-selective. So you got selective and non-selective. Those are your two types of beta blockers. Which one's safer? See, that's why I don't want you to remember 2 and 1. They both affect 1. One of them affects 2 also. So you can't differentiate them by numbers. You differentiate them by terms. Selective and non-selective. The one that only focuses on 1 is considered selective. The one that focuses on 1 and 2 is considered non-selective. Selective would be safer. Selective would be safer because it's selective to the heart only. Non-selective means it can go to various places in the body. It's not selective. It'll find any old beta receptor. Do you understand that? Any beta receptor it can attach to. That's why it's called non-selective. If it's selective, it's only going to affect 1 or 2 receptors. What? Huh? Oh, I thought you had your arm up. Now pay attention. If they ask you about a non-selective beta blocker, that's the one that they're usually going to ask you about. Propanolol. If they ask you about a non-selective beta blocker, that's the one they're usually going to ask you about. You never give propanolol to somebody with a respiratory issue or a vascular disease. You never give a non-selective beta blocker to someone with a respiratory issue like asthma, COPD, or somebody with a vascular disease. This will cause constriction of the bronchioles. A non-selective beta blocker shuts off the sympathetic effect, which is dilation of the bronchioles, and causes the bronchioles to do what? The sympathetic nervous system dilates the blood vessels that carry blood to the extremities. When you block that effect, what happens to the blood vessels, which is decreasing the amount of blood that you're carrying to the extremities? So if they got a vascular disease, you can't do that. You need to know that about this med, this propranolol. Propranolol is a really highly given med, but it's a non-selective beta blocker, and you need to know that. Okay? Also, you guys got to know this disulfiram. This disulfiram. This is a type of punishment for drinking. It's called aversion therapy, where you get a negative consequence after you take this med if you drink alcohol again. And it doesn't just apply to the alcohol in the bottle. Mouthwash, hairspray, anything that has alcohol in it can induce this disulfiram reaction, which is going to make you very sick. Very sick. Okay? Nausea, vomiting, weakness, sweating, palpitations, hypotension. You have to teach the patient not only to avoid the alcohol, but products that contain alcohol. Are you listening to me? The hair dyes, there's all kinds of things that have alcohol in them. Okay? Very important. And then you have what's called naltrexone. Naltrexone reduces the craving for the substance. It reduces the pleasurable cravings of the opioids or the alcohol. Okay? And then you have the acamprosate. This decreases unpleasant effects resulting from abstinence, so the dysphoria, the anxiety, and the restlessness. But with this med, it can cause diarrhea, so they need to maintain adequate fluid because of the dehydration possibility. Okay, take the med with meals, and they can't take that med with pregnancy. We got that? Then you got medications to support withdrawal, abstinence from opioids. Remember that withdrawal symptoms occur within 1 hour to several days after stopping. Findings include what? How will they appear when they're withdrawing? They ain't going to want to what? They're going to have what kind of symptoms? Which includes runny nose, yawning, sweating. The hair is going to stand up, abdominal cramping, and diarrhea. There's also what's called methadone. We know what methadone is. Okay, the only problem with methadone is you get addicted to that. Okay? This prevents abstinence syndrome from occurring and removes the need for the client to obtain illegal substances. Okay, so the dependence will be transferred from the illegal opioid to the methadone. Methadone is also very expensive. They get these people hooked on this for life. They got to keep going to these clinics and getting the methadone. What's that? Well, he shouldn't.
I had a hospice patient at my job, and I used to always ask the hospice nurse about it. And she was like,
You sure he was on methadone and? Huh? Yeah, but it's that's stupidity. Take them off the methadone and then just put them on the opioid. That sounds like to me that's a money thing. That's a money thing. Okay? And I'm the point I'm about to make about these methadone clinics, I think that's the only reason why they still exist.
Yeah, because it's like $17 a dose.
Yeah. I mean, you could make the argument that it is a little bit more beneficial for the patient, but they're still addicted and they still have addictive behavior.
There's a methadone clinic right there by the courthouse, and I just passed two guys yesterday morning on my way here because they do the first dose at like 7 a.m.
Yeah.
And two guys are falling over the road and stuff if they're walking away. And I know where they just came from.
It's a money thing, man. Also, clonidine can assist with withdrawal effects related to the autonomic hyperactivity. Okay? Clonidine therapy does not reduce the craving for opioids. It just helps with the sympathetic reactions. It's going to cause dry mouth, so you get them chewing some sugarless gum or suckling some hard candy. Now, this is a good one. Buprenorphine. This is a good one here. This one won't get them high. They won't feel the high when they take this med. It's an agonist-antagonist used for withdrawal and maintenance. It's considered safer than methadone. Okay, there's a decreased risk for respiratory depression with this med and a decreased risk for dependence. Okay? The antidote is naloxone. We know that, right? You can give that IM sub-Q IV or inhaled. Okay? But that can lead to, or inhaled to reverse, rather, respiratory depression and coma and other signs of opioid toxicity. And then you got the med we talked about earlier for nicotine, right? What is that? Bupropion. And we said the thing we had to really remember with that is what? It reduces the seizure threshold, putting the patient at more risk for seizures. Then you got the Chantix down here, Varenicline. I don't know how to say that one. Okay, but that's Chantix. They can get these awful nightmares and suicidal thoughts. That's what you need to remember about this guy. Okay, it says unpredictable behavior, mood changes, and thoughts of suicide. Okay, it's banned for clients who are commercial truck or bus drivers, air traffic controllers, or airplane pilots. Then you got the nicotine replacement therapy. If they do take the lozenge, it dissolves in the mouth. It could take up to 20 to 30 minutes. Avoid oral intake 15 minutes prior to or during the lozenge. You got the nicotine gum and the nicotine patch. Remember, all patches. Look at this down here. It says remove the patch prior to MRI scan. All patches have a metal backing. Your Duragesic patches, those lidocaine patches, they all have a metal backing. So if they're going to get an MRI, it's got to come off. Okay? We got the e-cigarettes, blah, blah, blah. Now, we got cholinesterase, and this is where it gets confusing. I'm kind of glad it did this. But I'm kind of glad it did this. Okay? What am I?
Kind of glad it did that.
All right, very good. So you talked about cholinergics already this morning, right? We talked about cholinergics and anticholinergics. Now look at this, because this looks weird. It says a cholinesterase inhibitor. This is the part you can't afford to get confused, because this is confusing. If you ain't a student of about what I'm about to teach you right now, you lost points. And you'll never get these. But if you just give me the moment to explain this ridiculousness, this will get you some of them hard questions. Do you understand that? Pay attention now. You got to pay attention from every single word to understand this. I taught you earlier that the parasympathetic is responsible for the rest and digest. I taught you earlier the two main neurotransmitters that are involved in muscle contraction and relaxation were dopamine and acetylcholine. Are you listening to me? So you need to understand there's this area outside of the muscle called the neuromuscular junction, where the nervous signal fires down, tells the muscle to take an action. The acetylcholine tells the muscle to contract. This is the neuromuscular junction. Once the muscle has contracted, we need to do something with that acetylcholine. So there's an enzyme that sits down there called acetylcholinesterase. And it's going to erase acetylcholine. Acetylcholinesterase is going to erase acetylcholine. So if we give a cholinesterase inhibitor, we inhibit the enzyme that breaks down acetylcholine. Not acetylcholine. We make more acetylcholine available. Are you listening to me? When you give a cholinesterase inhibitor, you're not inhibiting acetylcholine. You're inhibiting the enzyme that breaks down acetylcholine. Are you listening to me? If we wanted to inhibit acetylcholine, we'd give an anticholinergic. A cholinesterase inhibitor is not inhibiting acetylcholine. What is it inhibiting? The enzyme that breaks down acetylcholine. So if we inhibit the enzyme that breaks down acetylcholine, what will this do for the acetylcholine level? Does everybody understand that? Understand that. If we want to inhibit acetylcholine, we're going to give a what? Anticholinergic. Not a cholinesterase inhibitor. You give a cholinesterase inhibitor, you're doing the opposite. You're doing what to acetylcholine? When you give an anticholinergic, you're doing what to acetylcholine? When you get a cholinesterase inhibitor, you're doing what to acetylcholine? Do you understand that? Okay? Anticholinesterase agents and have two categories, either irreversible inhibitors or reversible inhibitors. Okay? They're used to treat Alzheimer's and Parkinson's disease and reverse the effects of neuromuscular blocking agents following surgery. Okay? The prototype med they say here is called what? What is the prototype med here? Neostigmine. What is the prototype med here? So if we got something that's trying to cancel out our acetylcholine and make you weak, wouldn't they want to do that for surgical procedures? Do we want those muscles becoming rigid? We go give them a muscle relaxer. When we need to get them muscles back to contracting, we need to get some more what? Acetylcholine. And we're going to do that by giving them some what? Which is going to block the breakdown of acetylcholine. Are you listening to me? Are you listening to me? There's also the stigmines and the edrophoniums. The stigmines and the edrophoniums. The belief is that Alzheimer's is caused by lack of what? Acetylcholine. It's caused by what? So that's where that donepezil is going to help make more what available? We got that? Cholinesterase inhibitors prevent the enzyme cholinesterase from inactivating who? So when we give a cholinesterase inhibitor, what are we doing to the acetylcholine? If I give a stigmine, what am I doing to the acetylcholine? If I give a stigmine, what am I doing to the acetylcholine? If I give edrophonium, what am I doing to the acetylcholine? If I give donepezil, what am I doing to the acetylcholine? If I give a stigmine, what am I doing to the acetylcholine? If I give edrophonium, what am I doing to the acetylcholine? If I give donepezil, what am I doing to the acetylcholine? And these are called cholinesterase inhibitors. Are they inhibiting acetylcholine? Are they inhibiting acetylcholine? Huh? I'd take off about that much. Are they inhibiting acetylcholine? Cholinesterase inhibitor. Just a little. Make them point cut it. Neostigmine. That's why it treats a condition called what? What's the problem with myasthenia gravis? You ain't got enough what? Why? Because that acetylcholinesterase is doing what? Breaking it down. What is the condition of myasthenia gravis? What is myasthenia gravis? What is myasthenia gravis? We're going to lock down, shut down, and all that, right? We're going to shut down. We ain't even going to try to do nothing. We're going to shut down. Myasthenia gravis is an ascending. Ascending. Starts in where? The lower part of the body. It's a neurodegenerative disease caused by the lack of what at the neuromuscular junction? You know this answer. What do we need at that neuromuscular juncture that we've been talking about for the last 20 minutes? Acetylcholine. What do you need for, listen, come on, go back to the basics. Here are the basics. They're right here. What do you need from muscle contraction, meaning strength, and muscle relaxation, meaning relax? Myasthenia gravis is about weakness, so therefore, which one of those two are you missing?
Missing the acetylcholine.
Correct. Not enough acetylcholine makes the muscle what? Too much acetylcholine makes the muscle what? You got the answers, man. Guys, you got the answers to the questions I'm asking. You just got them in chunks. You got to take the chunks and connect them. You go back to the basics. When you get in that array, go back to the basics again. What do I need for my muscle to contract and relax? A balance between what two neurotransmitters? Acetylcholine, dopamine. And if I don't have enough acetylcholine, what condition will that result in? Myasthenia gravis. And if I have too much acetylcholine, what condition will that result in? Cholinergic crisis. Myasthenia gravis, cholinergic crisis when it comes to the acetylcholine. Guys, you can't go into NCLEX not knowing this condition. You can't enter the NCLEX room not knowing about myasthenia gravis. Why? Because it's a dangerous condition to have. Because it can shut down respiratory and swallowing muscles. It is a dangerous condition to have. Why? Just as is multiple sclerosis, amyotrophic lateral sclerosis, Guillain-Barré syndrome, Parkinson's. All of them have two things in common. What are those two things? Breathing and swallowing. Breathing and swallowing. If you don't remember nothing else, when you go in that NCLEX, when it comes to those neurodegenerative conditions, you better remember that they're going to affect. Are you listening to me? Everybody focus on lunch. That's the problem. Old lunch got us trumped. Okay? We need to fast. That's what we need to do. Fast. Okay? All right. Be back at 1 o'clock.
Oh, he got something.
No. Oh, you think I'm letting you go because of me?
No, don't listen to me.
Okay, because I'm going to say we could stay. You're doing a good job, Ronald. Yeah? You worked last night? Oh, the kids had you? Oh, I can understand that one. Sometimes that boy don't go to bed 2, 3 o'clock in the morning.
así te lo ponen.
Oh no, you need to go. They wet. They wet. Oh. Jeffy, you getting lunch while you out? You gonna have
Yeah,
fun?
yeah, I should.
Okay.
I should. Yeah. Yeah.